Here we go. Good morning. I'm calling this hybrid public roundtable to order. Today is Wednesday, May 7th, 2025. The time is 11 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health, holding this roundtable on the state of the district's opioid crisis and the work of the Opioid Abatement Advisory Committee. Since 2018, the district has been grappling with an opioid crisis that has tragically claimed the lives of 2,660 residents due to fatal overdoses. During that same period, the fire and emergency medical services personnel and community partners reversed more than 18,000 suspected opioid overdoses using naloxone. While the exact reasons are not yet fully understood, the district has begun to see a decline in fatal overdoses in 2024, with the Office of the Chief Medical Examiner certifying 174 fewer fatal overdoses compared to 2023. Thankfully, this positive trend has so far continued into 2025. As of last month, there were 333 fatal overdoses, representing a 34% decrease compared to the same period last year. However, the decrease in non-fatal overdoses has not been as significant, with 4,798 non-fatal overdoses being reported, a 6.3 decrease from the previous year. Fentanyl, a synthetic opioid 50 to 100 times more potent than morphine, was involved in most overdoses, both fatal and non-fatal. Furthermore, many individuals who died from an overdose had received treatment within the year prior to their death, including 46% who received mental health treatment and 29% who had received substance use treatment. The impact of this crisis has disproportionately affected older Black men, particularly those residing in wards 5, 7, and 8. Unfortunately, despite the overall reduction in fatal overdoses, the disparity persists, with Black men representing 71% of the fatal overdoses between February 2024 and January of 2025. Nearly 60% of the fatal overdoses involved individuals 50 years of age or older. Today's roundtable will examine the district's response to the ongoing opioid crisis, including the implementation and evolution of the Live Long DC, a strategic plan launched in 2017 to combat the opioid epidemic. We'll also dig into the work of the Opioid Abatement Advisory Commission, a 21-member body established by the council in 2022 and launched in the fall of 2023 to provide recommendations on the use of the opioid settlement funds. I don't see any of my colleagues at the moment, but as they join us, we'll certainly turn to them. We're going to turn to the public witness testimony. So we will now hear from our public witnesses. All witnesses will have 3 minutes to testify. I know this gives some of you heartburn, but trust me, you can do it. It's not because we don't find what you're going to say important, but we do want to make time for everyone to be heard today. And you're certainly welcome to submit longer written testimony for the record. There is a clock right in front of you, so please be conscientious of your time. And for those who are testifying virtually, there's a clock here on the Zoom, and then we will get there as well. All right, I have 4 seats, and so we'll go through there. Oye Olueya, the U.S. Representative of DC. George Kerr, founder and CEO of G3 Associates. Judy Ashburn from Samaritan's Inn. And Chad Jackson, who's the chair of the Opioid Abatement Advisory Commission. Okay. I don't see OAA. And I know that there's a group that would like to go together. So, Thaddeus Winston. Winston, excuse me. Great. Okay, Mr. Kerr, when you're ready. Okay, I'll go to Judy and we'll come back to you. Oh, got to turn on your mic. Turn on your mic. There you go. Yep.
Good morning, Chairperson Henderson, Marcia, council members that are not here. My name is Judy Ashburn, VP of Clinical Programs at Samaritan Inns. Addiction, as defined by the American Society of Addiction Medicine, is a chronic relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. It is considered a brain disorder because it involves functional changes to brain circuits involved in reward, stress, and self-control. I am here to express my gratitude to the Opioid Abatement Commission on behalf of Samaritan Inns and 2 other substance use disorder providers for the opportunity to be among the first to bridge the gap between opiate treatment and supportive wraparound housing without stigma. In December 2024, Samaritan Inns received a grant from the OAC, and by January 2025, a new supportive transition housing program was open for men and women who had completed an average of 4 months of residential treatment. 99%, 18 of our 19 beds, were filled almost immediately. There is no effective opiate treatment without recovery-oriented supportive transition housing before and after brief hospitalization for stabilization, and community-based inpatient residential treatment that supports continuous long-term outpatient treatment. For more specifics, you can refer to my written testimony. I'm also here to speak on behalf of the DC SUD Coalition as we stand by the critical role of the OAC and their hard work as the most effective community collective voice for opiate-addicted individuals and families. The OAC has also been a welcoming place for opiate treatment programs to contribute their subject matter expertise at a time when the district opiate overdoses continue to climb, while for the first time ever nationally, the opiate crisis is in decline. The SUD Coalition providers, in collaboration with community stakeholders, welcome the chance to work hard, hand in hand with the OAC and the payers to continue this work to build infrastructure that supports a sustainable opiate and addiction recovery-oriented treatment continuum. We see the need for a feasibility study that specifically addresses the gaps in treatment outcomes and transition housing. To close on a sad note, last week Samaritan Inns temporarily closed its Women with Children's program and child care center, the only one in the city for the past 10 years, due to an inability to find an insurance carrier for the child care center. There are many barriers facing the agencies that serve this most vulnerable population. Some mothers struggling with opiate addiction could not go to detox because they had no one to keep their children. They often suffered through withdrawals in treatment, especially if MAT was not immediately available. So the SUD Coalition, in partnership with OAC, must engage the health systems to address these many gaps, aligning and creating strategic partnerships to win this war on drug addiction. Thank you. Happy to answer any questions.
Thank you. Just a question. Is that clock working?
No.
It is not. Okay. Ashley, if we could let Ashley, I'm sorry. Just 1 second. If you could let the support services know that the clock is not working on the table. Thanks. So what we'll do, Ashley, instead, I'm sorry. Okay, is we'll have to use the sound. Okay, so that folks will know, and we'll try to get that.
We can see the one on the screen over here, but it's not as obvious. It's not as.
Oh, okay. So there's one option available. Okay, we'll go that way.
Yeah.
All right, George.
Good job.
Thank you.
Oh, there you go.
There you go. Thank you, and sorry for that. I am George Kerr from G3 Associates. I also serve as a co-chair for the Harm Reduction OSG for Live Long DC. I also serve as the co-director of the Harm Reduction Program at Westminster. Our Harm Reduction initiative is a beacon of hope dedicated to preventing substance misuse through comprehensive education and effective community coordination. We strive to empower district residents and stakeholders about the fundamentals of harm reduction and the complex reality of opiate use disorder, shedding light on its associated risk and compensation strategies that can mitigate harm. By fostering collaboration and engagement within the community, we create a supportive network that empowers individuals and families affected by substance use. The faith community plays a vital role in this mission, stepping forward as allies in addressing the pressing needs of those grappling with substance use disorder without judgment. Together, we work tirelessly to cultivate understanding, compassion, and practical solution. As a co-chair of the Harm Reduction OSG of Live Long DC, I am passionately dedicated to our mission of empowering and uplifting our community through a analytic of the latest data. We are grateful to have introduced the new Opioid dashboard. This powerful tool provides us with real-time information, allowing us to pinpoint and respond effectively to the unique needs of those we serve. In Washington, D.C., we have a wide range of invaluable resources at our fingertips. Naloxone, and because the public is watching out, I'll say it very quickly. The life-saving medication acts swiftly to reverse opiate overdose, providing a second chance to those in crisis. FDA approves and straightforward to use. Naloxone can be administered even by those without medical training. Its painless delivery requires no complex setup and comes in pre-measured doses, dramatically reducing the chances of overdosing era. Westminster, DC is one of the official sites. Harm reduction vending machine, I'm just going to skip forward and recommending groundbreaking tools, drug testing machines, safe consumption sites, strategic collaboration among funders, partners in our current political environment with federal funding. We must ensure strategic alignment across DC agencies to optimize our outcome. We need the most appropriate partners to deliver services, provide our workforce is appropriately trained by pivoting response. I appreciate your consideration and I'm available for questions.
Thank you. Sorry, they're working on the issue. So that wasn't you. You were on time. They were just working on the issue. All right, Mr. Jackson.
Okay. I was told that I had 5. I'm going to work it. I think I can make it in 3. Here we go. Thank you for this opportunity. My name is Chad Jackson. I'm testifying today as the chairman of the Opioid Abatement Advisory Commission. In addition to being the chair of this commission, I'm a person in long-term recovery. So this is personal to me. This is something that I believe in and something that I do not only as a career, but in this position and have a personal feeling for. The commission first met in October 2023. I was selected as the chair of this 21-person body. I stated in the first meeting and continue to believe that we're serving a vital role recommending how the city should allocate the opioid settlement monies to reduce opioid overdose deaths and to fight opioid disorder in the district. The importance is evident when we look at the tobacco settlement spending, which the district receives an F from the American Lung Association, spending less than 45% of the minimum recommended level. I have some numbers, but it's not really that important. On the national level, only about 3% of the tobacco settlement money was spent on tobacco-related issues. So this commission has an important role to play to make sure these monies get spent in the right places. To date, the commission has received a little over $25 million and dispersed or awarded about half of those dollars in grants and contracts. All of the settlement money that we have spent or allocated has been directly related to reducing opioid use disorder, overdose deaths, or something in the vein of overdose deaths. We haven't gone into other areas. I'd like to highlight a couple of the things that we've done. $750,000 has been invested with FIMS to create an opioid response team, which is cutting edge and something that I think is extremely notable and something to be lauded. We can provide buprenorphine on site of an overdose reversal and then continue to follow those people that we've reversed for several days to help them get some stability in their life. In cooperation with Councilperson Henderson, we spent $400,000 with the OCME to support forensic toxicology testing, which is extremely important to know what our problems are and how they're working. $250,000 to the DC Hub for peer workforce development. We're working on some contingency management programs that I think will be remarkable for the city. I believe that as important as the commission is, I think we have some issues. I agree with the council person that we have a commission way too large for what we're trying to do. 21 people. I've heard you say that's too big a number. And so I don't disagree that we have challenges, but I'm proud of what we've done. Thank you.
Thank you. And Mr. Winson.
Good morning, Ms. Henderson. I'm Thaddeus Winson. I'm the Overdose Survivor Outreach Program Coordinator at MedStar Georgetown University Hospital and a person in long-term recovery. At MedStar Georgetown University Hospital, we've observed a concerning new presentation of non-fatal overdoses in the past 2 months. Brought in by ambulance, found down, pinpoint pupils unresponsive to Narcan is generally the chief complaint. This is disturbing evidence that xylazine and mediotimidine is becoming more prevalent here in DC. We have no way of testing for this, as alpha-2 agonist adulterants metabolize too quickly in the patient's body for bedside testing. This leaves our emergency room physicians looking for other answers, even when a patient has a chronic history of opioid use. Such situations can be time-consuming for our physicians. I have 2 potential requests for the Opioid Abatement Commission to consider: nalmefene or Opfi to rule out respiratory depression for 12 hours instead of a Narcan drip, which also can be expensive, and funding for research on rapid alpha-2 agonist testing of some sort. Xylazine test strips have been useful so far, but they are only preventative. I'm unsure if xylazine test strips will detect mediotimidines. I assume they will not. Naloxone saturation strategies should remain in place, as they have proven extremely effective. It took 10 years for our hospital to add fentanyl to its urine drug screen panel, and while that was expensive, it was necessary and a relatively easy objective to accomplish. With this wave of alpha-2 agonists, we face an unknown challenge and cannot afford another 10-year wait. It is worth ringing the alarm and learning from Philadelphia and Baltimore strategies, as they have been dealing with similar issues for years before us here in DC. I must add, on the treatment front, the DC's Medicaid substance use disorder treatment centers are inundated with institutionalization, as CSOSA and the drug courts pay twice the Medicaid rate. We must negotiate to raise the Medicaid rate and separate CSOSA's population into a consolidated facility. The patients I encounter every day in the hospital refuse our DC services due to the severe institutionalization. It presents as a major barrier to treatment for patients who seek recovery. If possible, separate these facilities and pool the costs. This is worth considering for our population that generally wants to recover. I understand that this is a controversial topic, but I feel it must be addressed. I appreciate the work of the Opioid Abatement Commission has been doing unpaid here in DC. It has filled some of the larger gaps that we have here, unifying our city in the fight against the opioid epidemic. There is still much work that needs to be done moving forward. I thank them for their efforts. Thank you.
Thank you. And thank you to all of the witnesses who testified. Ashley, if I'm just going to be honest with myself, you put me on 7. I do have some questions. Mr. Winston, I want to follow up with you because you're the most recent sort of person who spoke. Can you say a little bit more in terms of the institutionalization sort of view, or I guess effect or treatment in terms of our centers?
This is going to be an unpopular opinion, but because CSOSA and the drug courts pay 2 times the rate, it's much preferred to have people who pay more in these facilities, so beds are less available. And then we have a lot of people coming from the courts that want to get out of a sentence, want to get out of jail, whereas my patients who want to stop using drugs are there for a different reason. So again, it's a controversial opinion. I'm not saying that the people in jails don't deserve treatment. I absolutely believe they do. However, that institutionalization bleeds into the treatment that regular DC citizens are trying to accomplish and can be a huge barrier.
Okay. Judy, you are nodding in agreement. Is this something else that you share his opinion on this, or
Well,
you just turn your mic on?
I do agree with the service rates being twice as much and the
Okay.
decreasing capacity with DBH, DHCF service rates. That's why I was shaking my head.
Okay.
So we can raise those rates. We can negotiate with Medicare for better rates. But we could also work to separate these facilities and have equal treatment, but less institutionalization permeating our whole SUD structure.
Okay. That makes sense. Thank you for your testimony. Oh, sorry. One other thing. You also said that xylazine, it's harder to detect.
It's nearly impossible to detect at bedside.
Okay.
So you can test a substance with our test strips that we give out at the hospital, but in a urine drug test, in a blood test, it metabolizes too quickly in the body. So there's tranq, which kind of we all know now, but there's also rhino or hippo, which is the mediotimidines, which is a whole nother subset of alpha-2 agonists.
Okay.
And who's to know what's at play here? As far as the state of the opioid epidemic goes, we need to be on top of these things. We need to be, allocating funds to the DC Forensic Lab to do better testing. I don't really know what that entails, but I'm just ringing the alarm of in
Yeah.
the past 2 months, we've seen 40 of these identical presentations, and that's concerning.
Okay. I mean, we have the surveillance report, so it's a little delayed, right? You're not going to get it in that immediate sort of interaction, if you will. Is there some other state that's doing this better?
I don't know if they're doing it better. I mean, Philly has had this problem before us. Baltimore saw it trickle down after them, and now we are third. But I think that the conversation should be had with their opioid abatement commissions and whatever they're doing to figure out best practices.
Okay. All right. I wanted to turn to Judy as a grant recipient of the Opioid Abatement Commission. You said that you all received your grant in December of 23, and then you were able to turn around your program to open in January of 24. That's rare that someone is able to turn it around that quickly. How'd that happen?
Well, we had been planning for it because we had men and women in our long-term in the 3.5 and 3.1 residential drug treatment. And we believe this Samaritan Way is our continuum of care. And if we put all that energy into that 3 to 4 month breaking down, building trust, we always were looking for supportive transitional housing. We were looking at respite. We really didn't get that proposal in time. And so this is another form of transitional housing because there's so much needed. And we had some staff already involved in our long-term recovery program, and we had beds available because we're moving our SRO residents out that have signed leases.
SRO, please.
The single resident occupancy. So they have signed leases.
Everybody got it for everyone.
Yeah, yeah.
I have to break down these acronyms, not
Yeah.
just for me, but also for those who may be watching who don't have the.
So we're moving out the people with signed leases because you really can't make any requirements of them program-wise.
Yeah.
And being able to do this transitional supportive housing, they now attend outpatient, go to 12-step meetings, they have individual therapy because I believe we're treating the underlying issues, not just the symptoms of opiate, drug, alcohol use.
Okay, and so you got it in December of 23. The grant was for a year. It was, yeah. How many people were you able to serve?
So we started in January. We've served 24. 17 are there. Some of them had to serve some time in jail. 2 of them relapsed, but the remaining of them have been there for the last 3 months.
17 are there. So what's the timeline? Like, how long is someone able to be
Well,
there?
because the grant is kind of for a year, we're looking at, I believe that 18 months to 2 years is the best time frame
Okay.
for them to get really solid footing. So get employment, they have escrow accounts, save their money, get sponsors. And that's all part of getting that groundwork laid. So they can be there for up to a year.
Okay. All right, I'm going to turn to Mr. Jackson. Can you speak a little bit about the grant making process and the thinking behind 1-year grants versus 2-year or longer?
Sure. I think that the grant making process I am still learning a lot about the grant making process. We have a procurement issue in DC that I don't think anybody is trying to say is otherwise. It's hard to move this, and I think it's supposed to be in a bureaucracy hard to move money around, but it takes a lot of time, and we have to go through a lot of processes that the Office of Opioid Abatement does a very good job at now that they've got a full staff. Once we receive a grant, it takes several months to process that grant and get the budgetary requirements put into place and get them through grant management and fiscal coordination and things like that. So we've seen some delays. And I think that's part of the process and part of what we have to deal with. I don't know that there's an easy way to change that. And I don't think it's a DC centric problem.
Okay. In terms of the grant rounds in particular, is it open to any idea? Are there particular goals we're trying to reach? Talk a little bit about that process.
The Opioid Abatement Commission set forth 14 different criteria on which to give out grants in areas that we felt were underserved in the community based on some of the things that are shown in the gap studies that have been done in the city. And we modeled our grant request around filling those 14 gaps. What we're doing now is we're starting to see the results of those grants. It has been a slow process. It would be my goal in the Opioid Commission to then look at the ones that are successful and the ones that are really working and then refund those further rather than going into a new process. But I think we also need to look at a long-term infrastructure solution with some of this money rather than just send it all out as grant money.
So what do we call success for a grant?
In the biggest sense of the term, we call it saving lives. We call it people that are not falling in between the cracks in the system. More specifically, the grants are all set up with specific goals in them of what we're trying to achieve and meeting the goals that they're set up to achieve. A lot of the grant proposals, when put into action, produce different results than were expected. And we want to see that we're actually meeting the goals that we approved for the grants, whatever those may be in the different areas, whether it's interacting with the community. The commission had an overriding desire in the grant process to interact on a one-on-one level inside the community. We funded a lot of things to churches, a lot of things for working in communities and reaching people that this population of men over 50 is very insulated or seem very insulated to a lot of our traditional marketing techniques and methodology. And so we were working to move things into the community so that we could have one-on-one interaction with peers, which are walking success stories, and church religious communities to help move this forward.
So let me ask it a kind of a different way. Now that for many of these grants, the grantee has had, not many, but some of them, the grantee has had the funding for at least a year. Probably now we're looking at a year and a half because June is around the corner. Is there a process that the commission will do to evaluate whether or not past grantees have been successful in meeting the goals that they outlined at the beginning?
Yes, most of that falls under the Office of Opioid Abatement, which has grant management staff now. One of them was hired just this year. And I know that Dr. Barker has been going and visiting the grant, the people we've made grants to, and we've been doing an assessment process that will be reported back to the commission at some point. And we're going to try to have regular reporting back from the grantees like Judy.
Okay, so I'll ask Dr. Bazaran about that because if Judy's grant was only for a year and it's now May, has anybody asked you for a report?
We give monthly
No.
We give monthly reports.
Right. Has anybody asked you though, as like a summary, your grant exit report?
You mean that we're, what we have to do in September with the year end?
Yes, year-end report.
Year end report. We're doing it monthly, but we are going to request an extension
Okay.
at that time so that we can at least get through January with the money that was on the budget, because we had to change the length of time based on the money, the grant award.
It's important to understand that a lot of these grants did not get funded as quickly and didn't start as quickly as Judy's did. So we're seeing, some things are just getting started. One grant is hung up in the mayor's freeze right now for being signed, and that
Gotta move
happened a
faster.
couple of weeks ago. So, I mean, even though the budget is separate and everything, that's the process. And so we're
Yep.
still working to get this money out the door, and some of it has moved very slowly. Slower than I would like, but not any slower than I think we would expect.
Yeah. I would say this. I mean, obviously, Mr. Jackson, I share your desire to ensure that the opioid settlement funds are not spent in the same way that the tobacco settlement funds are spent. But I also know that anything within government, if it sits for too long, it becomes enticing for others to just swipe. And we have a tendency to do that on the EOM side, right? They'll just empty out any fund that's left, regardless of what it is, and then we have to go through this whole rigmarole to put the money back. That's actually what happened at the very beginning of this. We had money set aside that got swiped that we had to put back because it's not legally allowed to be swiped in that way. But thank you for the work that you're doing and the work the commission is doing. Thank you to all the witnesses who testified. If you didn't provide your written copy of your statement, please do so for the record. Thanks so much. Do you need to? Okay. All right. I'm going to call the next four while we're trying to check out what's happening here. Dr. Adeku Ofobu, apologies if I am pronouncing your name incorrectly. Dr. Edwin Chapman, Joshua Lynch from Matters Network, and Quentin February. All right. Okay. Professor, are you ready? Or, I'm sorry, I was just going to, whoever's going first.
Okay.
Dr. Chapman.
Hi, Councilwoman Henderson, thank you for this opportunity. I'm going to act kind of as a facilitator just to introduce the other panelists. But as you know, I've been involved in opioid treatment for about 25 years. And I was a member of the Opioid Abatement Commission representing the medical societies. I've kind of had to step back. When you get close to 80, you need to pace yourself and pick your fight. So, but our experience has been since 2015, we noticed the increase in fentanyl and the fact that we had patients who were doing well with doses of buprenorphine over 24 milligrams up to 32 milligrams. And fortunately, we had the Howard University College of Pharmacy to investigate that and actually prove that was fact. And that has become the standard of care by the FDA as of December 26, 2024. So if you look back, you could understand how many of our patients did not get the right dose of buprenorphine. And even today, we're still getting PAs from some of the Medicare Advantage plans with dosing caps at 24 milligrams. So this is not, it's going to be an educational process across the country. But we hope to further that work with the Howard University College of Pharmacy, because we now have a number of patients who are in their 60s and even 70s and tolerating fentanyl, cocaine, amphetamines, and alcohol all at the same time without overdosing. So there are genomic studies that we're hoping to pursue. The second thing is we've noticed that the age of my patient population now is around 60, but there's another burgeoning population in the DC detention center. As of 2023, there were 250 patients on medication-assisted treatment, 2024, 400, and 2025, over 500. So the question is, if we have a 98% penetration of insurance, why aren't our patients, why aren't these individuals getting treated outside before getting involved in the criminal justice system? And the final thing is, we think that we can coalesce all of this around having a unified database. And we've asked Dr. Joshua Lynch to give a brief presentation about the Matter system. So I'm going to stop there.
Good morning, Councilwoman, and also to Marcia Huff as well. And thank you so much for this opportunity to speak today. As Dr. Chapman stated, I am Adaku Ofebu. I am a pharmacist. I've been a pharmacist for about 10 years, and I am also an assistant professor at the Howard University College of Pharmacy. And I wanted to first start by thanking the council for their efforts with the Live Long DC initiative, and I also wanted to thank the council for allowing pharmacists to have provider status in the District of Columbia. And with that being said, because we now have the ability to practice with a larger scope of our license, that gives us an opportunity to provide more assistance with the opioid use disorder crisis in the district. So one of the things that we've noticed as a barrier is that there are not enough practitioners who are actually providing prescriptions for MAT-related medication-assisted treatment options. And one thing that is great about pharmacy is we're the most accessible healthcare professional. In addition, we have the ability to do disease state management, medication optimization, all of these different things. We can order lab tests, we can do assessments and point of care testing. So we have all of these capabilities. And currently, from what I saw from the Open Data DC resource, there's about 13 substance use disorder locations across the district, but there's 141 pharmacies also in the district as well. So if those pharmacies were able to work out collaborative practice agreements with existing prescribers, that could increase the reach of people that are able to help bring patients into treatment. So that's one of the things we also wanted to suggest as a recommendation. Additionally, another challenge that we've seen is the dosing of the actual medication, because there's been a lot of barriers because of, with insurance and all of that, that some patients are not able to get the dose that they need. And we've realized from our research looking at Dr. Chapman's data that a part of that is attributable to a genomic variations that lead patients to needing a higher dose than what was previously FDA recommended. So one of the things we would like to promote is the use of pharmacogenomic testing as a means of individualizing treatment. And with that being stated, pharmacists are uniquely poised to be able to use that data as a part of the clinical decision-making process in order to help with that dosing. And finally, another barrier is, as you stated, we know that the efforts of Live Long DC have resulted in a reduction in opioid overdose deaths, but we're not exactly sure how that came to be, right? And so Howard University were able to do data analysis and help you understand exactly where, what has been working and what hasn't been working. Thank you very much.
Thank you. Dr. Chapman, who's next in your lineup? All right, Mr. February.
Good morning, Ms. Henderson. My name is Quentin February. I'm
Okay, I need you to either lean into the mic or you could pull it closer to you as well. There you go.
Good morning, Ms. Henderson. My name is Quentin February. I'm a returning citizen. I came home December 31st to Dr. Chaplin office the first week of January of this year. He been helping me. He been medicating me with Sebastian with my opium addiction since I've been home. I still haven't had no Medicaid. I applied for Medicaid since I've been home. They told me it was in the process. I went back down there. They still telling me it's in the process. I've been home for 5.5 months and still have no Medicaid, no food stamps, no anything. My mom is very supportive of me, so that's who I stay with. And that's who's been helping me a lot. Also with Dr. Chaplin also helping me. I am a DC native. I've lived in Washington, DC all my life. My father had died from an overdose of fentanyl of last year of November. So I'm very against fentanyl overdoses. So that's why I'm here right now giving my speech about the opium crisis. Also, it's a lot that I see me being on the streets, you know, what homeless is, and I'm considered being homeless as right now, you know, I'm living underneath my mom's household, but I'm still considered homeless. It's just basically I'm just being pushed around. I applied for everything I supposed to apply for, but nothing hasn't came through yet, and I've been home for 5.5 months once again. Thank you.
Thank you. Mr. Lynch.
Good morning. Thank you for having me today. I'm Joshua Lynch. I'm an emergency physician and associate professor of emergency and addiction medicine at the University at Buffalo, Jacobs School of Medicine, the chief medical officer of the Matters program, a program designed to facilitate linkage to treatment and prevent people from falling through the cracks, and someone who has lost his uncle and brother-in-law to an opioid overdose. I want to begin by recognizing the district's work through many programs, Live Long DC, the Abatement Commission. Through this groundwork that's already been laid, we have the opportunity now to step into a more coordinated, equitable response to the epidemic. With funding already allocated, we have the opportunity to build on that foundation and further refine our strategy, highlighting really kind of three important areas: reducing morbidity and mortality associated with opiate use disorder by ensuring rapid access to treatment, and and initiation of medication for addiction treatment, or MAT; saving medical care costs by preventing unnecessary, costly, and repeated hospitalizations and emergency department visits; and reducing criminal justice costs by linking individuals into treatment rather than holding them in custody. We have to invest in systems that facilitate reentry with strong and immediate linkage to addiction treatment, particularly medication, and focus on minimizing gaps to medication for the treatment of addiction and opiate use disorder. The time period after release from incarceration is one of the most dangerous time periods for someone with opiate use disorder. Without seamless care, transitions, and continued access to medications like buprenorphine or Suboxone or methadone, overdose risk remains very high. So I'd like to talk to you about a solution. A model that addresses this need and would greatly enhance DC's current efforts and save more lives is the Matters program, the medication for addiction treatment and electronic referrals. Launched in New York State in 2016 and now operating in Allegheny County and the greater Pittsburgh area, Matters has demonstrated success in improving access to treatment, engagement, obstacle mitigation across a wide variety of environments: hospitals, treatment courts, prisons, jails, and many others. Additionally, the Matters program has taken operational experience and produced many peer-reviewed publications to further expand its impact. Just a couple of the program components are emergency telemedicine assessments that can provide a same-day buprenorphine prescription for people who can't get to a brick-and-mortar place or somewhere for in-person care, real-time electronic referrals to high-quality treatment providers that provide appointment slots that are accessible 24/7 without making phone calls, waiting on hold, or hoping for a call back the next day. Harm reduction education and supplies such as naloxone and drug testing strips for fentanyl and xylazine that are offered by mail and through a series of outdoor harm reduction vending machine programs. We're also evaluating medetomidine and nidazine test strips for further drug contamination, and persistent follow-up care and care coordination through support services program that follows up with people at 24 hours, 30, 60, 90 days, anticipating them falling through the cracks and trying to keep them connected to care. Thanks for having me today.
Thank you. All right, this one was meaty. I have lots of questions, but I'm going to start, Mr. February. So when you finish, where'd she go? There's Rebecca on my staff. She has her hand up. She handles Department of Healthcare Finance. We can get your information and we're going to check with Healthcare Finance and DHS about your Medicaid application because it shouldn't take 5.5 months in order for it to be approved. In fact, the process should have started before your release, but we're going to get the info and if anything, we'll follow up or. Oh, okay. And then this is Dr. Bazaron, who's the director of the Department of Behavioral Health, and they also have a staff person who can assist as well. Dr. Chapman, have you just been covering this as uncompensated care since January?
Say that one more time.
If he hasn't had Medicaid, but you've been treating him since January, have you just been covering this as uncompensated care?
Yeah, so we obviously have worked with the Department of Behavioral Health and the SOAR director, Dr. Hunt, and we're able to get temporary medication through 35 K Street.
Okay.
My office doesn't get paid, but we
That's
get paid.
what I'm saying.
You know,
I just gave a speech a couple of weeks ago. We were talking about what should healthcare look like in this moment of disruption. But one of the things that we often we forget, but we need to remember is that providers are small businesses too, and that you also need to get paid.
right.
And so I'm sorry that it has taken this long, but we're going to try to get it figured out. So once you're done, just go talk to Rebecca. We just need to get your full name, birthday information so that we can check with Department of Healthcare Finance on that. But thank you for being here and for providing your story and your experience. And I'm very sorry for your loss that you experienced last year as well. Okay. Dr. Chapman, one thing, for those who don't know, we email a lot, so I get a lot of things from you, but one of the things that I found compelling in the remarks that you talked about, sort of the growing number of people within the Department of Corrections custody that are now on MAT. To your knowledge, is there any communication with Unity Health, which is the organization that is providing health coverage in those facilities, around why they've seen such an increase that has occurred over, I think you gave statistics over maybe a 3 or 4 year period, and how better we can catch this before someone goes into the DOC system?
Yeah, so I actually had a meeting in my office with the Leadership Council for Healthy Communities, which is a faith-based group that I work with. And I must mention that they've just gotten 2 grants, one for opioid use disorder above the age of 55 and another for returning citizens. That just came through. So we had a meeting in the office in January with the medical director of DOC and Dr. Richard Debotes. Dr. Beth Jordan, Dr. Debotes came to my office. They met with the Leadership Council for Healthy Communities. But our analysis is that the problem is on the outside. They do a tremendous job. They have a tremendous program in the Department of Corrections. But once they come out, just as Mr. February described, there are other people like him who may come out and get insurance but don't have housing. They don't have a job. So my suspicion is that the recidivism is the failure outside. They're not getting connected and then they're going back in. I don't know that to be a fact, but I think if we have a database that we can follow, we can prove or disprove that. That's one of the theories. But certainly, we want to do a better job as a community. And that's why we got the churches involved and trying to get more physicians involved and more providers involved, which has been a challenge also.
Okay. Dr. Afogabu, you know, one thing we hear a lot around is the prior authorization challenges with regard to MAT, but you're sort of speaking around getting the right dosage.
Yes.
How do we get this correct? Because I feel like in some instances, we're kind of living in this in between, which is the federal guidance, the insurance guidance, and then what health providers and the research is saying. So how do we sort of
Harmonize everything?
Yes.
Great question. I think part of it is everything I think starts from the FDA. Whatever the FDA guidelines say is what everybody tends to follow, right? And initially it said 24 was the max. And so what happened was all of the insurances followed suit. Now the information about the genomics relating to the dosing came after the FDA's guidance on how to dose buprenorphine. And I think the challenge is trying to get that information incorporated in. So they did eventually make the change, but now to have that trickle down to all of the insurance companies, I think is where the challenge lies.
Okay.
So one of the challenges we've seen from the prior authorization standpoint is that some of the Medicare Part D plans allow patients to get 32 with a prior authorization, but some do not. And because many of the patients are becoming Medicare eligible and they're dual eligible to boot, even though the DC government allows patients to get over 32, like up to 32 without a prior authorization, if they become Medicare eligible and then the Medicare is primary, then you run into a problem.
Oh, I see.
You run into the problem where you
So we're
can't
talking
get
about, got it. All right, I'm putting all the
Another barrier.
pieces together in my
Another
head
barrier.
here. You know,
There's one other issue,
okay.
generic versus brand.
Oh, you're trying to complicate the thing even further. But
If she could speak to that.
yeah, I mean, for those who are not tracking what we're talking about here and sort of the not jargon, but like the terminology of the various programs, when we're dealing with individuals who may be over 50, a lot of your patients who are over 60, now we're talking about Medicare and not Medicaid.
Yes.
And the Medicare alphabet soup of Part D versus everything else, it gets complicated, but go ahead.
I can explain. So for everybody, so there's different parts of Medicare. The part that deals with prescription drug coverage is Medicare Part D. And sometimes some of the Advantage plans may have a Part D component to them, but basically if we're talking about Part D, we're talking about prescription drug coverage. And so the thing is, if you have Medicare and Medicaid at the same time, you have to bill the Medicare first before you bill the Medicaid. So the Medicare covers things, whatever's not covered by Medicare, you then bill to Medicaid. So because buprenorphine is typically covered by Medicare, whatever they're going to allow for Medicare is what's going to be covered.
The standard regardless of what the other says.
Exactly. And so that's the issue, is that some of the patients are not able to pay for the remaining 8 milligrams if they need that. And so they get stuck in a situation where they literally cannot get more than 24, even if we do genomic testing, we find that there's a mutation, and that mutation dictates that they should have 32 milligrams worth of Suboxone per day.
Yeah. And I think that's important also to note is that while states have more flexibility in terms of Medicaid, that does not exist for Medicare, particularly for Part D.
Yes.
Okay.
Yeah.
All right. I'm a little over my time. That's okay.
Okay.
Because none of my colleagues are here, so I'm going to keep going. Dr. Lynch, I wanted to ask about the Matters Network program that you all do in New York State. You mentioned a couple of the components, the emergency telehealth appointments, the harm reduction supplies that you can receive through the mail, the care coordination, et cetera. How do you get patients referred to you?
Thanks for asking. So there are a variety of front doors. The program was built initially to help facilitate linkage for people that were in the emergency department to treatment.
Okay.
That was kind of an obvious first step. Very quickly, we realized that there are patients that need connection in many other environments. So the inpatient side of the hospital, on the scene of a 911 call, I think we're going to hear about some great work happening in DC right now on the scenes of 911 call, initiating medication. But oftentimes, after that's done, if someone doesn't want to go to the hospital, now you're sitting in their living room or on their front porch, linking them to treatment from that environment is also helpful and life-saving.
Who's doing the majority of the on-the-ground work that you're talking about there? Are you guys using peers or someone else?
So peers play a significant role, and peers are actually also offered as a linkage. So you can not only get linked to a treatment appointment slot that's been provided by one of many treatment organizations across the state, but you can also be linked to a peer for kind of a virtual handhold or coffee while you're waiting. On the ground, it depends where you're at. So let's say you're in jail and you've been receiving care while you're incarcerated, you're about to be released. We know how sensitive that transition is. having the ability to pick an appointment tomorrow at a place where you want to go to, not where you're told to go, before you walk out and have a plan, is super important. That's just one other environment. Drug courts, other court environments, community outreach groups. There are many places to access the system and find a high-quality treatment provider that already exists. I've seen on Live Long DC, there's a kind of a directory on the map of lots of great places. I suppose that making the connection, though, is still a problem.
The warm handoff piece
Yeah.
for sure. And, you know, I think there's some challenges around, while we have a great resource in terms of, you can go to the website and look up the folks, right? I don't know who's accepting patients. We don't necessarily know when's the last time this phone number or contact information has been updated. So if the provider moved, now I have something that's a bit dated. So we definitely have some more work to do on that. But what you guys are doing in New York definitely sounds very interesting, especially sort of the linkage connection piece, right? With the idea of, I'm not giving you an opportunity to slip through the cracks, whether it be at the hospital, before you leave, corrections.
On the sidewalk, on the
si-
front porch, anywhere.
Right.
Just two other very important pieces. So we worked really hard to identify high-quality treatment organizations that would already agree to accept you without insurance, with polysubstance use disorder, with co-occurring mental health diagnoses. But if we did all that and you picked a place and you couldn't get there, that the path stops.
Yeah.
So we provide transportation vouchers to everyone that's referred. And also, if you don't have insurance, or if you're navigating through the Medicaid process, we'll offer you a voucher to cover up to 2 weeks for buprenorphine, no questions asked, no application, no waiting, no nothing. We just want you to not have a gap in medication while you get yourself sorted out, whether that's with insurance, whether that's with with an appointment, and having people be able to make choices and not being given a list of numbers, which I did myself for many years, that don't work, that are, shut off, that don't have any appointment availability, is really key.
What do you guys do about the housing question?
So, housing question, there is not.
Or housing problems, not really a question, it is a problem.
So, as we've grown our support services program, which is basically like post-referral engagement, it's a couple phone calls, trying to stop people from falling through the cracks. We're looking at who's identifying housing problems and what exactly they are, and then trying to link them with local resources. It's not as rock solid as the transportation and medication assistance yet, but it will be.
Okay, all right, thank you so much for being here. If you guys could provide your testimony for the record, that'd be helpful. Thank you so much. All right, we're gonna go on to the next panel. Let me just say, Dr. Afogbu, I would love to follow up in sort of thinking about the strategy of how we, I guess, elevate this conversation on the federal level to deal with the Medicare part specifically, because I've got some constraints, but we know some people, so we could try
Thank
on
you.
that.
Absolutely.
Yeah, thank you. Okay, Gordon Simmons from ERP Health. Oh, okay. Ralph Williams. Okay. Betty Gentel. There she is. Patricia Quinn. Ralph Williams. Oh, that's you. Oh, you're on there twice. My bad. Ooh, okay. And Janita Fintley, who is actually here in person, although was on the list for virtual. Yep. All right. All right. Mr. Williams, if you just hit the button in front of you and when you're ready.
Okay, good morning, Madam Councilwoman, and thank you for this opportunity. And I want to thank the Opioid Abatement Commission and just all opioid abatement team at DBH for this opportunity. I'm the founder and CEO of a program called the Nehemiah Project that over time I started out really just doing transitional housing for returning citizens and providing wraparound services. But through the blessing of the opioid grant, I now have something that really is kind of a first in Washington, D.C. Anyway, it's a respite program based on SUDs. And I've heard just a lot of testimony this morning that is all related to me because that crack that people keep falling into is basically housing. That's what happens. You know, when anybody is seeking treatment, in the treatment process or whatever, if you can't find them, you know, that's what breaks down the treatment process. And so we through the guidance of some people from Tennessee, Dr. Sam McMaster and Siobhan Morse, they actually helped write our grant. And they are, I would call recovery housing experts. They one is on faculty at Mahara University and one is on the faculty at Baylor University. They are both in Tennessee, but they have came up here regularly and they're written into our grant as consultants to help us roll out what we do. So I just want to say that it's just been an honor, you know, to be able to do what we're doing and especially and being tolerated because we're doing something for the first time. And so you had no idea how it was supposed to look. And so we're being helped to build what we're doing, but we know that I believe it's the integral part. You know, what it basically is people overdose. They can come from a stabilization center or straight from the overdose or wherever, and they can come to our house, stay there for up to 3 weeks. We have 18 beds. We're on Sheriff Road in Ward 7. We have 18 beds, and what we do is try to manage them until we can try to get them in treatment. We also provide bedding for someone who may go to detox, and the Samaritan Ends or SUMS or RAP drug program may have a bed for them, but it's not going to open up for 2 weeks or a week. They can come and stay in our facility until that bed opens up, because, you know, if they go back out in the street, they're never going to get there. So we you know, I just will ask that we just get a chance to continue to build out what we're doing, because I think that our component is key to solving a lot of the problems. And what I want to submit for further exploration is that respite housing may need to be considered a different level of care than level 1 point whatever, 2 point whatever, and 3 point whatever. It's a different type of level of care, and that will, you know, just help. I'm going to stop there because I don't want to keep talking.
All right, thank you. Ms. Gentile? Also, I don't think I've ever seen you in person, so hello.
I know. Greetings, Chairperson Henderson and members of the committee. Thank you for the opportunity to testify. My name is Betty Gentle. I'm the Senior Director of Advocacy and Public Policy at SUM Incorporated, a DBH certified provider and active member of the DC Behavioral Health Association and the SUD Provider Coalition. SUM has served DC since 1970, working in this manner on interconnected crises of poverty, homelessness, and hunger. We launched our residential treatment program in West Virginia in 1989. Within a year, we opened our first long-term affordable housing program because clients told us that what they needed most after treatment, a safe, stable place to continue their recovery and rebuild their lives. Then as now, we understand that housing isn't just supportive of recovery, it is essential to it. We're encouraged that DBH and OAC increasingly recognize housing as critical to the behavioral health continuum. We especially appreciate the OAC's leadership in expanding transitional housing funding and commend the Office of Opioid Abatement staff for their responsiveness and partnership. We were proud to receive both the Restore Recovery Residences and OAC Strategic Impact Grants to support transitional housing in our Leland program in Ward 7, advancing a recovery infrastructure that works. Together, these grants support up to 20 transitional beds with a target stay of 90 to 120 days. They provide a vital bridge for DC residents returning from treatment in West Virginia, covering meals, supplies, recovery materials, and life skills development, as well as 24/7 staffing. SOAR funding also enables intensive case management to connect residents with outpatient care, job training, mental health services, community-based support, and harm reduction resources. This work closely aligns with the long-lived DC 3.0 strategy to expand recovery housing. However, progress is undermined by DBH bureaucratic inefficiencies. All 3 of our recent opioid-related grants were significantly delayed in start dates and compressed into shorter timelines, forcing us to revise project scopes, adjust staffing levels, and recalculate our monthly costs. Because grant dollars cannot be spent retroactively, the costs we incurred during those delays months had to be absorbed by our organizational budget. The SOAR Recovery Residence Grant was expected to begin May 2024, but started March 2025, reducing the project from 18 to 8 months. The OAC Traditional Housing Program Grant, initially slated for October 1st, 2024 to September 29th, 2025, was delayed until March 2025, reducing the award by over $380,000 to fit the shorter timeline. The Community Outreach Grant serving Ward 5's North Capitol Corridor, which supports opioid education, prevention, harm reduction, and pure lead drop-in services, was delayed by 5 months. These delays threaten program sustainability and reduce our capacity to serve while placing the burden on the very communities most impacted by the opioid crisis. We urge DBH to streamline grant disbursements and improve communication to protect these investments. Finally, to maximize impact and accountability, funding improvements must be paired with clear policy direction. My written testimony includes recommendations from the SUD Provider Coalition, urging the districts to prioritize housing and social determinants of health in any response to the opioid crisis and future substance use epidemics. We are committed partners in this effort. Thank you.
Okay, before we go to Ms. Quinton, you were talking super fast. We were trying to take great notes. So I'm going to ask you to go back in your paragraph where you talked about you were supposed to get the grant here, but you got it here. I think one, you said it reduced the grant from 18 months to 8 months or 6 months or something. Repeat everything you just said, but like, take your time.
The SOAR Recovery Residences Grant was supposed to start in May 2024,
Okay.
but just recently became able for us to spend down in March 2025. So that went from 18 to 8 months. The Transitional Housing Grant from the OAC was delayed. It was supposed to start in October, but also just started in March.
October of 24.
Yeah. Which is why we had to, go back and revise the budget for like personnel costs, monthly costs for software, things like that. So
Okay.
that reduced the award amount by about $380,000.
So it was delayed and the award amount got reduced.
So the budget had to be revised because now we aren't, it won't be spent down for that full original timeline.
Got it.
Yeah.
Okay.
And then the Community Outreach Grant, which I think maybe the council that you all created for Ward 5, the North Capitol Corridor, was also delayed by 5 months.
All right. Councilmember Parker will not be.
But they all are in effect now.
Okay. All right. And the October 24 to March, you said that was a housing grant.
Yes, that's the one from the OAC.
From the advisory.
Opioid abatement, yeah.
Okay, so
And the SOAR one, the first one is SOAR, but they're both transitional. The first one is SOAR, the second one is from the commission.
okay.
But they're both transitional housing.
All right. 3 different grants, 3 different pots of money, 1 commonality. They were all late.
Yeah.
All right. Well, I'll ask some follow-up questions. Sorry about that, Patricia.
No,
Go
no
ahead.
problem. Tricia Quinn, DC Primary Care Association. And I've submitted my written testimony, so I'll just do a summary. The main recommendation is that the Opioid Abatement Advisory Commission take a good look at a few government commission reports that have come out around our SUD system over the past couple of years. One that DCPCA worked with JSI to complete in 2021, and then the Pew Charitable Trust report, I believe coincided around that same time or maybe slightly later. And to look at those reports and really assess which of the elements of those that have been recommended we are kind of successfully approaching and achieving, and where the gaps continue to exist, to hold that against the ways in which the commission might move forward in further investments. And I'll say, given the non-recurring nature of the opioid settlement funds, to keep the focus on infrastructure investments and in innovation, things that are difficult often for the district to invest in. I think there's an opportunity with these non-recurring funds. And in particular, there's kind of a drumbeat here around housing and around social needs more generally. In the JSI report, people impacted by SUD said that addressing some of these social needs was more important to them than even treatment or the continuum of care, that it's so foundational to someone's ability to recover that we really need to focus on those social needs. And from an innovation perspective, the JSI report also charged us to look at innovation in payment models around SUD. I know for our primary care providers, we've been doing a lot of work around value-based contracting and how does that look and how within the context of a community health center. And I don't know how much we've really brought along the SUD provider community into that framework. So JSI made that recommendation and we would support that. So happy to answer any questions.
Thank you. Ms. Finley.
Good afternoon. This is my first time testifying. I just have a quick question. I printed out some pictures. Is it okay for me to drop it off there?
Or you can give it to Ashley and she can bring them up. Yep.
I can give it to Ashley
Yeah,
afterwards.
she'll walk over.
Oh, okay. I wasn't sure. I'm sorry.
It's okay.
So to introduce myself, that might be helpful. My name is Nita Finley, and I serve as the managing partner for Compy Recycling Center, and I'm also the founder of Compy Recycling Center's Medical Ascension Program. First, let me thank the DC Council Committee on Health, as well as you, Councilmember Henderson, for inviting our organization, Compy Recycling Center, to share with you our work to reduce the opioid misuse and our efforts to stop the opioid epidemic in the District of Columbia through innovative outreach and prevention efforts. Just quick background, Medical Ascension is a healthcare career pipeline program for youth and young adults that has two primary goals. One, to provide youth and young adults with the tools to pursue healthcare careers. And number two, activate our youth and young adults today as trusted health and wellness leaders for their communities, families, and social groups. Since Medical Ascension's inception in 2020, more than 690 youth have completed our program. In November 2024, we received a grant and support from the DC Department of Behavioral Health through the DC Opioid Abatement Funds, where we began activating our Medical Ascension youth into Level Up Against Opioid Epidemic Leaders. Our grant-funded project is a youth-driven and place-based solution to counteract the opioid crisis that disproportionately affects our communities in wards 5, 7, and 8 in DC. 6 months into our grant, more than 45 Medical Ascension youth have been activated through our trainings that improve their knowledge on opioids, prevention strategies, refusal techniques, and information needed to steer clear of opioid misuse. Our youth leaders also gain the skills needed to help their community members, family members, and friends and peers who are misusing opioids seek recovery. With our youth training model, Medical Ascension youth leaders have been facilitating their designed game that they created themselves, Level Up Against Opioid Epidemic game for their peers and near peers at 6 different recreation centers, which is in the pictures, as well as different schools throughout wards 5, 7, and ward 8 for their peers and near peers, so they can also become stewards to prevent opioid misuse with the information. More than 60 youth have participated in these trainings. They're fun but gamified, which provides them opportunity to learn in a very comfortable space. Additionally, 6 months into our grant, our Medical Ascension youth leaders have also run their own Medical Ascension Level Up Against Opioid Epidemic community health stations, which is also in the pictures, where more than 120 adult community members, family members, peers, and near peers at gathering spaces in our priority wards, such as at Martha's Table in Ward 8, UDC Congress Heights campus in Ward 8 as well. Our Medical Ascension level leaders have also designed, filmed, and edited and produced their own culturally informed public service announcements for opioid overdose prevention, which have gained more than 2,000 views on our Instagram at Medical Ascension. With this proven infrastructure of activating our trained youth as trusted stewards for our communities, in 2026, we hope to expand the project by having our trained youth run their own games at churches, senior wellness centers, and men's groups in wards 5, 7, 8 to further explicitly target Black men over 50. With the popularity of our community health stations, we hope to develop even more hands-on and visually appealing attractions to further encourage our Black male visitors to stop by our mobile locations throughout wards 5, 7, and 8, so they can gain information about opioid abuse, learn about reduction factors, increase protective factors, and change their perceptions, attitudes, and behaviors to reduce opioid misuse. Again, thank you for listening, and I appreciate the opportunity to present.
Thank you. Thank you to this panel of witnesses for your testimony. All right, I'm going to start with you, Ms. Finley. to see if we have a theme here or if what some has gone through is a bit unique. When were you notified that you were awarded the grant, and when did you actually receive the funding?
We were notified in November, and we received the funding pretty quickly. It was a surprise to us. I want to say November or December as well. We were notified November 5th, 2024, and we received the funding within maybe 3 or 4 weeks. There was also an opportunity to get an early release of the money. That's not the proper terminology. What is it called? An advance. I heard someone in the corner give me a little cheat sheet. Yes, an advance.
Okay. That is rare.
Our executive director.
That does not often happen. All right, so now I got to figure out why that didn't happen with some. Because you were notified in October of 24, but you didn't get it till March of 25 for the commission funding.
Let me see. That was the date it was supposed to, the program was supposed to actually start. I don't have the notification date written down for the commission grant, but the notification date for the SOAR grant was July 13th, 2024.
Okay. All right. Okay, let me go back. Ms. Finley, you said you guys have served 690 since 2020. Specifically speaking, and I don't know if you can sort of break that out, but in terms of using the opioid settlement funds, how has that allowed for you all to expand or grow your program in terms of the number of students supported?
Oh, that's an excellent question. It has allowed us to attract more students because we have new elements to the program. So the PSA is a new element, the community health stations is a new element. The carnival that we're going to be producing in the summer is a new element. And it's just been a wonderful way to attract new students as well as even get in community involvement involved. So we've been able to expand our partnerships. We've got MedStar on as a partner now. We've been doing the best that we can to leverage the funds to bring in more partners, new students, family involvement, community engagement. We've just noticed an exponential increase in all of those.
Okay, great. Ms. Gentle, I know that Councilmember Parker isn't here, but I do want to ask how things are going in terms of the work that you all are doing on North Capitol Street. When we expanded the substance use outreach grants, and we're thinking about including Ward 5, North Cap certainly came to mind, given the range of activity that sort of happens there at the North Capitol Street, New York Avenue intersection. And also, I know that some is over there, and the work that you are doing in that part of the community actually makes you an excellent partner for this work. But I'm curious how it's going.
Yeah, it's definitely going well. And like that's where our main campus is located. So not only are we able to do that outreach to talk about opioid education, prevention, et cetera, we're able to integrate that education into, because that's also where our community resource center is located, where people come to eat breakfast and lunch every day. And we also have a day program that occurs during that time period. And so we're able to utilize those funds there, as well as having that support for outreach. We also are able to leverage it to get people to come into the other services, because on that same campus, we have medical care, dental care, as well as that's the linkage to SUD as well, if folks are ready to go into treatment.
Yeah.
So yeah, so it definitely has been a great partnership. And other than just that funding delay, it's worked very well.
One of the things that has worked really well in other neighborhoods where we have done this has been, the workers or the organization working for that particular area doing sort of a street walk to introduce themselves to the businesses and the schools in the neighborhood to say, hey, I'm here. Hey, if there's something that comes up, an issue, et cetera. So for instance, if you see needles and you don't want to pick it up, you can call us and we'll take care of it. Have you all done that work?
Yes, and we also were doing that work previously and already had those connections with the community, just because, as you can imagine, so many people they come in from the shelters on like the UPO vans. So we attract a lot of people to their residential neighborhood. Mundo Verde Elementary School is right there. We have a very, very good relationship with the neighbors. So I think that's one of the great things, that we already had those relationships and we're able to like really deepen them and to grow, add like a coordinator that's able to lead that work.
Yeah. Okay. Thank you. Ms. Quinn, I have a sort of philosophical question for you, which maybe not be a little bit fair, but you're the only one on the panel who's actually on the commission. It's been a little over a year now. When you hear about some of the grants in terms of where the funding has gone, have you given any thought to, man, if we hadn't done smaller grants but just did a big something, would that have been a better use? I'm curious your thoughts on that.
I think there was an effort early on to not be sitting on the cash, right? And to like get some things out the door to organizations. And when you look at the folks who got those grants, those early grants, they are people who have been embedded in their communities for a really long time trying to do this work. So I wouldn't want to say, yeah, we shouldn't have done that. But I think you're raising something important as I'm thinking about infrastructure investments and what that looks like. And I have not done the research on this, but it's a place my mind goes when we're in a resource constrained environment. Are there models maybe in resource poor environments across the world that have figured out something about how you can humanely and less expensively provide the right kind of housing support for people who are in recovery? And that could be like a multi-million-dollar investment, but so many people who already spoke today, the housing piece is the absolute center to anybody's ability to recover. So partly why I want to go back to the Pew report and the JSI report is to figure out what have we not done yet that was recommended in those two pretty in-depth assessments of our system. And for sure, addressing social needs is one of them. One of the other things in the JSI report that I don't know that we've done talks about financial support or job opportunity support, just to try to help people get on their feet from a financial standpoint. What are the innovations there? Are there things that we could be looking at? I think it's worth putting it on the table if we have that idea that we've done the analysis, not just like, hey, here's my, this is exciting and we could spend $10 million on it, but we've looked at the assessments, we've pointed to where the gaps still exist, and we've thought hard about what are the right ways to use the money we have.
Okay. All right. I don't have any further questions. Mr. Williams, thank you so much for being here. I certainly asked some questions about respite housing, and sort of, as Quinn talked about, this is a theme that continues to come up. But if you all can provide your written testimony for the record, that would be extremely helpful. Okay, we're going to go to the virtual panel. Or I'm going to make an assumption that everybody else who's here, you're not signed up for virtual and intending to be testifying in person. Okay. All right. So for those virtually who are joining us, you'll need to affirmatively accept our invitation to become a panelist. I'm going to start with 4 just to see who's here, because I have 9. So if I go, well, 8, I go 4 and 4, then that's 2 panels. Shelby Wallington, Gail Avant, Tom Welsh, and Dr. Sevilla Kalamurthy. Oh, wow. Everybody's here. I think this is like a first that I've had happen on a virtual panel. Okay. Ms. Wallington, when you're ready.
Hello, and good afternoon, everyone. Is my sound okay?
Yes, we can hear you fine.
Perfect. I will get started. I first want to start off with thanking Chair Member Henderson and all of the other council members there today. My name is Shelby Wallington. I'm the Director of Housing and Wellness at Community Family Life Services. We target to serve individuals coming home from a period of incarceration, specifically women. I'm here to express my gratitude and appreciation to the DBH SOAR Recovery Program and Opioid Abatement Funding, in which has streamed CFLS for about 2 years with funding. The Opioid Abatement Program and funding helps us with our drop-in center. It also supports us with transitional housing for 5 women. And the SOAR program allows us to provide 6-month housing to about 12 to 15 women in the Northeast and Northwest area. Our programs provide safe housing, case management, basic necessities, and again, the drop-in center where individuals are able to come in and receive food, harm reduction kits, clothing items, and other basic necessities for living. They also receive connections and linkages to in-house relapse services as well as outside relapse services. We have a few partnerships with treatment facilities in the area who we found it crucial to support our clients in their recovery journey. I am really here to request and ask that additional funding continue to be pushed out into the community to support individuals with an opioid addiction and disorder. As a DMV native and a social worker, I've seen what the effects of opioid use can do to the community. And with the funding that we've received, we've been able to support and help at least somewhere between 20 and 25 women within the past 2 years, the past 2 fiscal years, with their sobriety. That is it. Thank you.
Thank you. Gail?
Yes, good afternoon, everyone, and thank you, Councilmember Henderson, for your work and your focus on families. I have to say that. My name again is Gail Abatement. I'm the Executive Director of Total Family Care Coalition. We are a nonprofit, and I'm also a longtime resident in Ward 7. So Total Family Care Coalition is a family-run organization. We are located in Ward 6, Potomac Garden Public Housing Community for over 20 years. And we was founded by 5 parents who wanted to get services for our loved ones in the community. And we are also a peer operating center. We want to thank publicly Department of Behavioral Health on the Live Long DC Opioid Prevention Campaign that we've been a part of for probably the last 5 or 6 years, and also the abatement funding that has come about, where now Total Family Care is going to be developing a youth peer case management system to help expand our family peer operating center. But on a personal note, I have a loved one. They have a drug addiction and mental health disorder. So over the years, the 5 founding parents have passed. I'm still standing. TFCC promote family holistic services to families and children. And we as parents consistently say our children are our future. Let us make it reachable for let us make it reachable for our loved ones. My family members continue to struggle with both mental health and drug addiction. This morning, our loved one reported for outpatient treatment. Our family is on the first day of our family recovery. We've been waiting on the sideline and supporting our loved one for 20 years, but we are encouraged that today will be the beginning that our loved one will become the person they was meant to be. And the 4 founding parents left loved ones with co-occurring disorder are still standing. Hope is real and recovery is achievable. So substance use disorder significantly impacts family. It leads to relational strains, psychological stress, financial challenges, and a host of other negative consequences. So what we want to say this morning that at TFCC, we promote family recovery. We want to see that in other organizations and situations. As parents, we must talk to our children. No script, just words from the heart. While we are parents talking to our children, they are talking and listening to others. Why not us? Studies show that loved ones with active family involvement significantly improve and complete their drug treatment or their treatment recovery program. So my recommendation, invest in family support. And another recommendation is provide clear understanding of children and youth participation in drugs and a true number to let us know about youth rates, death rates among young people. Thank you for your time and consideration, and I'm happy to answer questions.
Thank you. Tom?
Can you hear me okay?
Yes.
Excellent. Okay. So my name is Tom Welch, and I'm the COO and co-founder of MAT Recovery Centers and the former executive vice president of BioCorrex Pharmaceuticals, where I still serve as a consultant. I have an extensive background in healthcare in the last 17 years, focusing on substance use disorder, and I've established strong connections with various stakeholders. I regularly correspond with the members of the Office of National Drug Policy Control on a range of topics concerning opioid, meth, and other addictions. Furthermore, I actively participate in research and development initiatives for non-addictive medications to combat substance use disorder. Along with my team at BioCorrex, we've successfully secured over $20 million in grant funding from NIDA, and our expertise has been recognized through numerous presentations at industry conferences. Today, I'd like to present 3 potential solutions for your consideration. Many well-intentioned individuals aspire to undergo detoxification, but are deterred by the severe symptoms that accompany this process. The MAT Detox device, otherwise known as the NeuroStim System Stimulator, offers a solution. This is a small ear-worn device that's been granted FDA clearance for pain relief and demonstrates efficacy in reducing withdrawal symptoms associated with opioid use. The device functions by stimulating cranial nerves in the ear with mild electrical impulses, which activates the brain's reward center to alleviate withdrawal symptoms. It's designed for outpatient use, and it spans about 5 to 7 days. For a comprehensive approach, this device can be combined with comfort medications as well. Another underutilized tool is the medication Lucemira. It's the only FDA-approved medication for lessening opioid use withdrawal symptoms. Lucemiras can be utilized alongside the MAT Detox device. The combination effectively manages opioid withdrawal and allows for transition to antagonist medications like naltrexone, or tapering to agonist or partial agonist medications for medical management such as bup, Suboxone, Subutex, Sublocade, and methadone. Lastly, I'd like to shed light on naltrexone implants. These were initially developed as long-acting versions of naltrexone and opioid antagonists, synthesized in 1963. Implants offer continuous naltrexone release for multiple months. One of the many significant advantages of naltrexone implants is their ability to help individuals with opioid use disorder adhere to treatment and avoid relapse. Studies indicate that naltrexone implants surpass oral naltrexone in preventing relapse and promoting sustained treatment. Additionally, they provide protection from overdose. Naltrexone has a dual indication for both OUD and AUD and effectively regulates the dopamine feedback loop in the brain associated with cravings. As a result, addiction becomes a passing thought rather than an overwhelming obsession for users. With a proven safety record and optimal results when combined with therapy, naltrexone implants serve as an invaluable tool. Implants are currently compounded at an FDA-inspected 503B facility and lack brand name approval, but they are available under state and federal compounding guidelines. The life-saving characteristics of these fully dissolvable pellets is supported by numerous studies, including one endorsed by our National Institute of Health in collaboration with St. Petersburg, Russia. This research ultimately paved the way for the Russian approval of protoxone. MAT Recovery Centers in Washington, D.C. actively employs these innovative techniques to combat addiction. I wholeheartedly recommend consulting with Dr. John Dombrowski, the former president of the American Society of Addiction Medicine, Maryland, D.C. chapter. His expertise lies in implementing these methods at his life-saving clinic, which can make a profound impact in areas where addiction treatment resources are in desperate demand. Thank you for your attention, and may God bless all of our collective efforts. Thank you.
Thanks, Tom. Dr. Kalamathi.
Yes, thank you. Good afternoon, Chairperson Henderson and members of the committee. My name is Dr. Siva Kaliyamurthy, and I'm the director of the Addictions Program at Children's National Hospital. As a top children's hospital in the nation, Children's National Hospital is deeply committed to the mental health and well-being of children, youth, and families in the District of Columbia. Children's National is proud to partner with the Department of Behavioral Health to expand access to substance use disorder services for children and adolescents in the District of Columbia. While we are not offering comments today on the Opioid Advisory Abatement Commission, we are grateful for the grant funding made available through the State Opioid Abatement Fund. This has been instrumental in advancing our efforts to provide comprehensive evidence-based care for youth affected by substance use since March of 2024. Specifically, the funding has supported the hiring of a psychiatric nurse practitioner at our addiction clinic, which allowed us to expand clinical services from 3 days a week to 5 days a week. This expansion has significantly increased our capacity to meet the needs of youth and families across the district. Since receiving the support, the clinic has served over 68 youth, providing medication management for substance use disorders, predominantly opioid use disorder, along with treatment for co-occurring mental health conditions. Notably, we're also seeing an increase in number of youth presenting with cannabis use-related concerns, which is reflecting a broader trend in problematic adolescent substance use. As part of our ongoing efforts to expand access, particularly in areas with the greatest need, we are working to broaden our reach in Ward 7 and 8. I am pleased to share that tomorrow we will open a second clinic site at Children's National, the ARC. Additionally, we have implemented a pilot naloxone distribution program in our emergency room, and we also have a universal substance screening protocol in our emergency room, which has successfully screened over 600 kids since its inception last November. These important initiatives are made possible through the State Opioid Response Grant provided by SAMHSA. Understanding that community engagement is essential in addressing youth substance use, along with treatment engagement in any clinical program, we are also utilizing the opioid abatement funds towards hiring and onboarding 2 peer recovery support specialists. We had initially encountered some challenges in the hiring process, but we are pleased to report that we have hired both specialists at this time, and they'll be joining our team in June. These specialists will proactively engage youth in community settings, assist with treatment retention, and provide on-site support to individuals who screen positive, helping to connect them directly with services. And we look forward to our peer specialists actively participating in community events, including collaborations with DBH's prevention centers and other local initiatives. We remain committed to working in partnership with the district stakeholders to ensure that all children and adolescents have access to high quality, accessible, and sustained treatment for substance use disorders. And I thank you again for the opportunity to testify today. I'm happy to answer any questions from you or the committee. Thanks.
Thank you. Thanks to this panel of witnesses, a lot of variety in terms of topic. Dr. Karlamurthy, I want to start with you, as I think you might be the first person who's testified today specifically about the youth population and kind of what's being seen there. I think for some people, it also might be very surprising that Children's National has to have a addiction program. I think when a lot of people think of this issue from a statistical standpoint, right, we have been talking a lot about older adults, but we're certainly seeing more presenting. I wanted to ask a clarifying question. You mentioned something in your testimony about cannabis, and I just wanted, I'm not sure I heard it correctly, so I wanted to give you an opportunity to clarify.
Sure. Just in terms of the first point about speaking about youth, most adults with substance use disorders did start using substances prior to age 18, and most of them do develop a diagnosable condition before they become adults. So we're happy that we're able to identify and support them earlier in their addiction process. With regards to cannabis, more recently, we have noticed a trend in terms of kids presenting to the hospital seeking help or complications from their cannabis use, whether this might be medical complications, including cannabinoid hyperemesis, which is a pattern where they have a lot of vomiting. We have cannabis withdrawal symptoms, which kind of leads to medical complications. But we're also seeing an increase in number of kids admitted to our psychiatry units with depression, anxiety, psychosis, and suicidal thoughts, who are also using a lot of cannabis.
Okay, that's helpful and also surprising, but at the same time, considering that the federal government has prevented any scientific research to happen on cannabis for ever, we're sort of seeing some of these effects in real time, as opposed to us having had a body of research as we're sort of changing the laws about its usage. So thank you. Have you all thought in terms at Children's, I mean, the expansion for your clinic, you said you're about to do a second location over at Children's National at the Arc. Some of this is coming from SAMHSA, which, you know, pay attention to what's happening on the federal side, but SAMHSA, for whatever reason, seems to be a big target in terms of cuts in terms of federal funding, as though no one in the country is experiencing an opioid crisis or epidemic. Have you all been thinking about how to continue this work? Because even though the money is going to go or might go away, the need is still going to remain.
So sustainability has been a concern for us in the absence of grant funding. So for the clinical work that we do, the challenge with engagement and retention and the volume of kids that we see, it'll be very hard for any one provider to do this work full time and make it sustainable just based on clinical billing. So we do rely on grant funding, especially for the peer position, because peers in a hospital setting still cannot bill in the District of Columbia. So we've had multiple challenges when we think about how to sustain this program once the grant ends.
Okay, thank you. Thank you for being here. Mr. Welsh, I want to follow up with you. I mean, throughout your testimony, I think you talked about a variety of different alternative options around treatment, whether it be the detox device, the implant to help with withdrawal. You talked about some other drug uses, et cetera. Are these treatments that are common, or are you talking about, we've seen evidence that this works, but nobody's doing it? I'm just, you know, when we bring something to, whether it be healthcare finance or the insurance companies, I need to have some evidence of, there are occasions where we are certainly pioneers, but I'm trying to sort of distill from your testimony what's something that is shown and prove effective in other jurisdictions versus the data says we should be doing this and no one is.
Sure. Every single thing I mentioned has studies backing it up, backing up its efficacy. The naltrexone implant has been used for 20 plus years successfully. And again, that's the one that our own NIH actually did studies with in St. Petersburg, Russia, and got it approved for them. Again, that one is utilized under state and federal guidelines at a 503B federally mandated facility. So we've used it in our practice for years and years, very effective. Lucemira is FDA approved, underutilized for opioid use withdrawal. Not quite sure why it didn't get marketed harder, but it is available. There are a number of addictionologists using it, but I don't see evidence of it being used nationwide as much as it should. And then finally, the detox device. There are a number of studies with comfort medications that show that it is very, very efficacious in opioid use disorder withdrawal.
Okay. For the device that you mentioned at the top that has been used for over 20 years, I think you said, is that Medicaid approved in terms of financing?
I know insurance oftentimes gets reimbursement for it. I'm not a billing expert, so I don't, if I were to make a guess, I would say Medicaid is not currently reimbursing for it.
Okay. Okay. If we could get a copy of your written testimony, that'd be helpful so we can follow up on some of the things that you talked about there. Ms.
Absolutely.
Wallington and Ms. Event, thank you so much for being here and for the work that you all do. It's good to sort of hear Ms. Event and Ms. Wallington, right, the positive success stories of the families who have been able to seek treatment, receive treatment and care in that way. So thank you. I don't have any further questions. Thank you so much to this panel. All right, we're going to go to our last and final panel. Just to sort of forecast where we're going and do my very best here. Okay, so we got our last four people, or however many are of that four are here. Then we're going to take a 5-minute break, and then we're going to do the government witness testimony. My understanding is that Dr. Bazaran is the only one who will be providing testimony, and then everybody else is just going to ask questions. Answer questions, and then we'll go from there. Okay, so Nadia Casey, Mikhail Kogan, Cindy Clay, and Queen Adisiu. Again, you have to affirmatively accept our invitation to become a panelist. It should pop up on your screen. Okay, I see Nadia. So when you're ready.
Good afternoon, Chairperson Henderson and members of the Committee on Health. I'm Dr. Nadia Casey, Program Director for Gardenzia Regional Addiction Program, also known as RAP. Thank you for holding today's public roundtable on the state of the district's opioid crisis and the work on the Opioid Abatement Advisory Commission. I'm pleased to be here testifying on behalf of RAP and all those we serve. RAP has been around for more than 53 years and has become an indispensable provider of substance use disorder treatment services to the district's most vulnerable residents. In fact, today, RAP is the only district entity that provides a full continuum of SUD treatment services, including crisis stabilization, 24-hour observation, walk-in assessment and referral, withdrawal management, detoxification, high-intensity clinically managed residential treatment, low-intensity clinically managed residential treatment, intensive outpatient, and standard outpatient across the ASAM continuum. According to the most recent data from the U.S. Centers for Disease Control, opioid deaths remain the third leading cause of death in the district, behind only heart disease and cancer, but ahead of strokes, chronic lower respiratory disease, diabetes, homicide, Alzheimer's disease, influenza, and hypertension. This calamity is the result of the district's long-standing underinvestment in the prevention and treatment of opioid addiction. By illustration, it's worth considering how RAP, the district's largest provider of residential services, has managed to stay open in recent years. The answer is simple. Over the past decade, RAP has received over $15 million in direct investments and subsidies from its out-of-state partner, Gardenzia. Without these subsidies, there is no question that RAP would have closed, just as Safe Haven Outreach Ministries and Salvation Army's Harbor Lights have done in the recent years. Without adequate and sustainable reimbursement rates for residential SUD services in the district, rates sufficient to attract high-quality providers and expand treatment capacity, meaningful change is unlikely. In the professional opinion, the status quo will persist. Notably, the district's reimbursement rates for residential SUD providers have not been evaluated through a formal rate study in over a decade, despite dramatic increases in operational costs. Under the current reimbursement structure, neither RAP nor any other safety net SUD residential provider in the district can achieve long-term viability. These outdated rates directly hinder the recruitment and retention of qualified staff and severely constrain overall program capacity to ensure that SUD residential services can meet the pressing needs of district residents. A comprehensive assessment of reimbursement rates is both an urgent and essential need. Today, RAP's residential SUD services for ASAM levels 3.1 and 3.5 are reimbursed at rates 35% and 44% lower, respectively, than in the state of Maryland. These ASAM services, involving clinically managed high and low intensity residential services, are essential parts of the continuum of care, which are necessary for a successful and sustained SUD recovery. In the absence of these ASAM services, individuals find themselves in a vicious cycle of recovery detox, relapse, detox, relapse. This cycle of rinse and repeat contributes significantly to the need for more intensive, expensive, and less ineffective crisis interventions, as well as increased public safety involvement. For context, nearly 80% of RAP's residential SUD services are ASAM level 3 and ASAM level 3.5. By illustration, if the district's SUD residential reimbursement rates were identical to Maryland's reimbursement rates, RAP would receive approximately $400,000 in additional annual revenue, or 11% more than we currently receive. Bear in mind that it is 15 to 20% more expensive to do business in the district than in the state of Maryland, which only compounds RAP's financial challenges. Under the district's current reimbursement rates and the fee-for-service nature of the reimbursement process, RAP is caught in a vicious financial cycle, and so are the district's other residential safety net providers. RAP acknowledges that we need to do more to improve our internal systems and are excited to share our recent progress. Still, no amount of internal improvement can overcome the math. To be sure, RAP is essentially genuinely interested in working with the district's talented staff of professionals to address our collective challenges. The first step is to conduct a rate analysis on the true cost of providing residential SUD services in the district and to create a plan to implement those rates. At that time, we would urge the district to transition from a fee-for-service reimbursement methodology to a flat daily rate for ASAM level 3.1 and 3.3, 3.5 medical services. As in the same case in the state of Maryland, RAP urges the Opioid Abatement Advisory Commission to use its resources to conduct the above requested analysis. In addition to conducting an up-to-date reimbursement analysis for residential SUD services, RAP urges the commission to conduct a thorough study of the actual SUD services capacity in the district, such as what
Casey?
services.
I've been super generous here, about 2 minutes, 2 and 30 minutes over your time. So if you could.
Oh, thank you. Thank you so much.
Thank you. All right. Mikhail? Dr. Kogan.
Thank you so much. Yes, thank you so much. Good morning, council members. Thank you for opportunity to testify. My name is Mikhail Kogan. I'm the founder and executive director of the Access to Integrative Medicine Health Institute in DC. I also serve as an associate professor of medicine in Division of Geriatrics and Palliative Care at George Washington University. Today, I would like to testify on the history, benefits, and AIM's commitment to partnering with the Opioid Abatement Advisory Commission to increase awareness and access to the whole person care. I recently had the opportunity to provide a detailed testimony at the OAC meeting, and I was very impressed with both the leadership and the commission and appreciate all the district is doing to address opioid abatement concerns. OAC's mission of addressing some of the city's most difficult healthcare problems is critical as it fills the largest gap. AIM is fully committed and already provided whole person care and plans to expand access to medical assisted treatment for patients in Ward 7, 8, and 9. But I want to talk a little bit about the complexity of addiction disorder. Unfortunately, the current medical treatments are never going to be adequate. They have no capacity to address the reason for addictions. And I'll delve a little bit into it. In 2021, Hartford Group studied stigma attached to the care of the MAT, medical assisted treatments. And turns out that over 50% of healthcare providers believe that it's just a drug substitution, that you basically take the addiction drug and you give something instead. Unfortunately, that's completely wrong. It will never help us, and it will continue having the problems unaddressed. The MAT must include a very comprehensive psychological, mind, body, and the whole body, the physical approach to addressing trauma as well as mental health issues. Over 90% of SUD patients suffer from complex trauma, and it's not addressed usually. The gold standard currently is the long-term counseling, such as cognitive behavioral therapy. Unfortunately, that's inaccessible for most current patients, particularly patients on Medicaid. However, there's been recent establishment of medical shared groups, which I will discuss in a second, that appears to be even more effective than a prolonged counseling due to group dynamics, peer review support, and also the whole body, a whole person experience of treatment that's done in such groups. AIM has been serving patients in DC since 2015 in close collaborations with different community members. In fact, today, as of today, of May 7th, we are restarting a treatment program for patients at Bradford the City, offering mind-body groups for chronic pain. During my recent presentations to the OAC, I had an opportunity to present a report on significant and relevant study in Vermont, and that's what I want to review first. In short, years ago, actually in 2019, University of Vermont successfully piloted a very complex chronic pain program that consists of 4 months of small groups of 10 to 14 patients who together 3 to 4 times a week practice mind-body approach, healthy cooking, therapeutic exercises, but also have opportunity to get individual holistic treatments such as acupuncture, massage, and physical therapy. This approach, now fully covered by Vermont Medicaid as well as Blue Cross, is saving approximately $500 per person per month after adding all healthcare costs. Most recent data from this group that's surveying this treatment program showing approximately 70% reduction in ER, significant reduction in pain medications, as well as cost of complex imaging such as MRIs. And I'm providing the link to the peer review study for the council members to review as part of written testimony. Based on UVM preliminary data, a similar program in DC will likely save cost within 12 months of implementation, and at least will cut ER visits by 50%. We all know that current ER visits is in crisis in DC. I had a patient a couple of weeks ago who spent 20 hours in GWER waiting just to get a regular care for emergency bleeding. AIM is perfectly positioned in collaboration with the community members, and we hope that program like this one can be funded. Thank you so much for the testifying, and I'm happy to answer any of your questions.
Thank you. Cindy?
Hello, thank you. Chairperson Henderson and the other council members for this opportunity to discuss one of our most pressing challenges, overdose-related deaths in our community, and what we as a city can do to address it. My name is Cindy Clay. I use she, her pronouns, and for the past 30 years, I have worked and led the efforts at HIPS, honoring individual power and strength to support those most at risk for overdose deaths and those struggling with active or chaotic drug use in our city. I'm also a member of the DC Opioid Fatality Review Board, and I wanted to highlight my appreciation and the importance of that group to bring community, nonprofit organizations, and government agencies together to discuss and identify ways the city can better address this issue. HIPS is a harm reduction-based organization serving over 15,000 people annually here in the district. We offer social and clinical services, syringe service program, overdose prevention, low barrier MAT, support groups, care management, and other services to primarily people of color, youth and adults who are unhoused and who struggle with drug use. We also serve a high percentage of unhoused LGBTQ folks in the city and also those that use both stimulants and opioids. HIPS helped pilot the original naloxone distribution program in DC in collaboration with HOSTA, and we continue to be one of the main organizations providing harm reduction services here in the city. With only 3 minutes, I won't have time to tell you about the 50,000 materials we distributed through our 3 harm reduction vending machines across the city, or the 287 people who accessed MAT at HIPS and achieved retention rates more than twice the national average. I won't have time to talk about our hotspot program, which reduced fire EMS calls related to overdose by 50% over the past 3 months. But what I can tell you is the collaborations that we have with HOSTA and DVH, we continue to try to ensure that active users in the city have access to low threshold life-saving interventions and support. But we are, as a city, falling behind on implementing innovative strategies that can save lives and address the issues that people who use drugs face. So I'm focusing on my recommendations. I want to say to support and expand the harm reduction vending machines. HIPS's own machines have provided over 50,000 individual pieces of harm reduction equipment to folks at times when our organization cannot be open or available for people. Provides a very low barrier access point. However, the machines have been more of a success than we expected them to be, and we're having problems with the current levels of funding to keep those machines stocked and also with staff to travel throughout the city and respond to calls for assistance. We also ask that you address the delay of the FTR drug checking machine implementation. FTIR machines allow community-based organizations to obtain real-time data on what is in the ever-changing drug supply in DC. Our community partners are ready to implement this. However, it has been in our budgets for over a year, and we haven't been able to implement it because of challenges in getting the program up and running at DVH. We need DVH to work with law enforcement and whatever other government agencies that we can to allow the community to do the work that government can't do, so that drug users who are bringing us supply that they are concerned about can know and make appropriate decisions on stopping bad batches that are happening in DC. I know I'm out of time. I'm really I have 3 more recommendations. We'd like you to support new innovative programs. There's an overdose prevention hotlines that have worked across the country and in other jurisdictions. It would definitely support our primary population right now who is dying of drug overdoses, which are folks who are in their homes and who are alone. and for whom a bystander naloxone administration isn't necessarily possible, and for whom there's no one there to call 911. This program was pitched to DBH but was not selected for funding, and we'd like DBH to consider innovative programs like that. We would also ask you to support DBH's and our own nonprofit organizations' administrative needs. Strong outcomes rely on good fiscal and programmatic management. I know that we, as well as other organizations that have talked today, have experienced delays. We think the fiscal team we have at DBH is great and amazing. However, we also know that there has been a lot put on their plate without any administrative or fiscal support. And that is causing delays in program implementation. It is causing problems in reimbursements, and it's been really, really challenging, and that department needs more support in order to better support the community partners. And then finally, I would, okay, I can wait, thanks.
I'll ask questions. It's okay. All right, Queen.
Good afternoon, Chairperson Henderson and members of the committee and fellow community members. My name is Queen Adesui. I'm a proud resident of Anacostia, and I've lived in DC for the last 13 years. I'm testifying today in my capacity as a partner of Reframe Health and Justice and as a longtime drug policy reform advocate. Thank you for convening this important roundtable and for the district's concerted efforts to address the opioid crisis, including but not limited to investments in harm reduction vending machines, decriminalizing harm reduction supplies that were previously criminalized as drug paraphernalia, and for the crucial support of peers in combating overdoses in our community. I join you today to highlight a significant gap in how harm reduction is currently understood and implemented in our city, and to urge this committee and the district at large to broaden our collective understanding and response. Harm reduction as a philosophy and as an intervention are more than just providing access to sterile drug use equipment, Narcan, and fentanyl testing strips. If our concept of harm reduction continues to evade safe consumption programs and comprehensive drug checking with FTIR machines, we are ignoring evidence interventions that saves and improves lives. The spectrum of harm reduction includes and honors abstinence and sobriety, but it also recognizes the nature of substance use disorder and the health needs of people who use drugs who are not ready or willing to cease use, especially in lieu of a safer drug supply. To meaningfully curb overdose deaths in our city, we must invest in and support in the establishment of 24/7 harm reduction centers that include safe consumption programming. These sites are also referred to as overdose prevention centers in our city, in the US and throughout the world. These evidence-based facilities, among so many other services, provide supervised spaces where people who use drugs can do so safely under the care of trained professionals capable of intervening at the earliest signs of an overdose, often before emergency interventions like Narcan are even necessary. On Point NYC provides a powerful example as the only sanctioned facilities in the US with a safe consumption program. In their first year of operation between November 2021 and November 2022, their centers intervened in 636 overdoses, 83% of which were resolved without needing naloxone, using oxygenation, agitation, and careful monitoring instead. This level of immediate medically informed response is impossible in isolation or on the streets. They intervened and reversed more overdoses in their first year of operation than the number of people we have lost to fatal overdoses in a given year, while not even operating 24/7. By December 2024, the cumulative impact of On Point's programs has increased substantially, serving 5,800 people, facilitating over 171,000 utilizations of their safe consumption spaces, intervening in over near 1,700 overdoses, and safely collecting 2.5 million units of hazardous drug litter. There has not been a single recorded fatal overdose at On Point or any facility that operates safe consumption in the several other countries that operate them ever. This model not only saves lives, but significantly reduces public and open drug use and drug litter in the communities that these facilities operate in, while also easing the strain on emergency services. Happy to answer more questions about this, but wanting to name that advocates have been calling for the opening of these centers for many years now, and it's going to be quite important for us to consider including this in our harm reduction strategies in order to save lives. Thank you for the opportunity to speak.
Thank you. Thanks to this panel of witnesses. Queen, it's good to see you. Haven't seen you in a bit. Hope you are well. Obviously, you know, the continuous advocacy that you all have done around safe consumption, but you already know what I'm going to say about this current political environment. That's great for other jurisdictions. It unfortunately cannot happen at this moment in the nation's capital. But I feel like we still need to talk about harm reduction and what that looks like fully. And so Cindy, obviously the work that you all are doing with HIPS is extremely important in doing some of this work. Can you talk a little bit about the delay in terms of, I think you said the drug testing machines?
Yeah, the testing machines that we'd like to purchase would be instrumental in launching what would essentially be a drug checking program, where folks can come in and we can get real-time access to what is in the ever-changing drug supply. And we know that by doing this, it helps give people like information about like bad batches or things. And we actually have users who are coming to us asking us to please help them figure out like what's in this particular batch should they, so that they can spread the information to their friends and to other people that they're using with. And so we just need the permission to purchase the machines, and we need the permission to start the program, and we need to staff this, we need to staff and support the implementation of these. This is happening in Maryland, this is happening in North Carolina, this is happening in like lots of other states across the country. They've been really, really effective in helping users make really informed decisions and also providing real time, not months after, information to public health officials about how the drug supply is changing and what we need to tell people to be careful of.
Okay. Just looking back at the responses from DBH in terms of, now this was from performance oversight. So this would have been January, February time, and they said that they are completing the following actions. Now, it doesn't say completed, it says completing. Legal review and sign off, defining support needed from MPD. They've got to re-engage the National Institute for Standards and Technology, training community providers to meet regulatory standards, and then also setting the data reporting requirements. Sounds to me like this isn't going to happen in FY25. It might not even happen in FY26, but you have the money.
We have it in our budgets to be able to spend the money. We just can't do it. Here's what I'm going to say is this isn't as hard as potentially it's being made, and the community organizations stand ready to support DBH in moving this forward. And we would just like the opportunity to do so and for it to become a priority at DBH. That's what we're asking for.
Okay. All right. I can follow up with DBH on that. Okay, let's talk about the vending machines. You said you're having trouble keeping them stocked. With what particular items, or is it everything?
It's everything. The machines are so popular that they're being emptied. Some of them are being emptied nearly every other day. Some of them are definitely emptied weekly. And while we have the funds for the machines, we do not have enough funds for the staff to go out and repackage them. And also the supplies that we can purchase with some of the grants are pretty limited. And so the machines have been a bigger success, I think, than any of us thought that they would be. And we're just saying that we need additional support, and we need that support to move through both DBH and or HOSTA or whoever, so that we can continue providing these services to the community.
Okay. Dr. Casey and Dr. Kogan, I'm going to ask one question of you guys each in terms of being on the ground as providers, board members of organizations. What should be the top focus in terms of the fight against the opioid epidemic for the district right now?
I can start, because I have to run. I have another meeting. Well, we're not actually treating the causes. We're patching things up. Like this vending machine is a great example. It's not actually treating the problem itself, right? The problem of drug abuse or chronic pain is very complex. They're whole person problems. Many of them are traumas, some of them are psychological, some of them, even as simple as nutritional problems. We don't have a system in place. The healthcare system in the current allopathic model completely failed to address this. And in fact, I predict the problem's going to grow. So we're I have a good slide for my students. We have a sink open, and water is running down. We're mapping the floor. That's what we're doing. We have to learn to shut down the sink. And for that, we have to provide an intervention a lot earlier. Not just by the time that people are completely addicted to the drugs. That has to be done too. but we need to have an additional approach, which is what I think why UVM model has been so successful. Now it's been rapidly implementing across all the country, by the way. I didn't talk about this, but I just give you the evidence that's highly peer-reviewed and published, and I provided reference for that.
Dr. Casey?
Yes, thank you. So one, of course, is the rate study so that we only have four residential SUD providers in the district can have the resources that are necessary. And the second is to consider a bundled rate. That creates an unbundled rate for levels 3-1, 3-3, 3-5 creates a significantly administrative burden in a time where there are certainly increased operational costs and limited access to appropriate services and supports.
Okay. All right. I don't have any further questions. If you can make sure that you provide your testimony for the record. Thank you so much to all of you for being here. As I telegraphed at the top of this panel, we're going to take a 5-minute break because we've been sitting here for 2 hours and 45 minutes. And we're going to come back to government witnesses, and then everybody can go have a late lunch. Thank you. Okay, Dr. Balzeron, if Dr. Zamore, Dr. Tolliver, and Assistant Chief Edwards want to join you at the table. Although I think we've lost our OCME friends. Okay. But somebody from DC Health is definitely here. I just saw them.
Yeah, he was.
Oh. Okay. Why don't you go ahead and get started? And then we can, hold on. I'm supposed to say a thing. Wait a minute. Okay. So we have our government witnesses, but before you begin, I need to swear you all in. No, so it actually is kind of important because I got to swear everybody in. Okay. Okay.
I guess you're right outside and coming in.
Yeah. For the sake of time, I'm just going to swear the two of you in, and then we'll get to everybody else when they get here. Okay. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
I do.
Great. All right. Dr. Balzeron, when you're ready.
Good afternoon, Chairperson Henderson, council members, and council staff. I'm Dr. Barbara J. Balzeron, Director of the Department of Behavioral Health. I am presenting testimony today on behalf of the Bowser administration to represent Mayor Bowser's whole of government approach to combating the opioid epidemic in the District of Columbia. In the interest of time, I've shortened my remarks, but my entire testimony has been submitted for the record. Mayor Bowser has mobilized 18 government agencies to address this issue. Today, I am joined by DC Health, Fire and Emergency Medical Services, and the Office of the Chief Medical Examiner. Mayor Bowser has provided nimble strategic direction and used all available tools to mobilize the DC government to fight the opioid epidemic with urgency, strong interagency coordination, and strategies. The Live Long DC plan, released in December of 2018, is a comprehensive plan, which is updated as needed to implement evidence-based practices, prevention, harm reduction, treatment, and recovery strategies proven to reduce opioid use, misuse, and related deaths. The Opioid Abatement Fund has been incorporated into the comprehensive strategic planning process. The Opioid Abatement Advisory Committee adopted 14 areas of focus to guide the use of the opioid funds. The most visible evidence of the results of our work is the significant reduction in opioid-related overdose deaths. The Office of the Chief Medical Examiner reports that the number of deaths in 2024 decreased by 34% from the year before. We never forget the lives lost to the disease of addiction due to the deadly fentanyl and the lingering impact on their loved ones. To be clear, the number of opioid-related deaths is still unacceptably high. Our response is to double down on what is working and develop new strategies based on the data and regular surveillance to address emergent needs, changes in the drug supply, or to apply lessons learned to improve outcomes. The decline in opioid-related deaths cannot be traced to a single reason, but is due to the implementation of a combination of strategies that are proven to achieve results, not just in DC, but nationally. I will now briefly review key activities within our prevention, intervention, and treatment and recovery framework. We start with the conviction that opioid overdose death is preventable. This approach brings in families, friends, and the community as vital partners in our overdose prevention strategy. Our harm reduction strategy includes widespread availability of life-saving naloxone and fentanyl test strips and a safe syringe program with mobile units to respond throughout DC. More than 367,000 naloxone kits have been distributed since the launch of Live Long DC. Naloxone is available in 130 community distribution sites in all 8 wards, including 29 pharmacies and public schools and 7 strategically placed vending machines and 2 returning citizens upon their release from jail. While we fiercely, I guess the question is, why are we fiercely committed to naloxone? Because it saves lives. More than 16,000 suspected opioid overdose reversals have been reported by fire and emergency medical services and community partners. Our commitment to harm reduction to prevent overdose death is matched by our commitment to expand ways for people to get into treatment and sustain recovery. Working with our partners, we have made it easier to access high-quality treatment through multiple entry points, including all 5 hospital emergency departments, all community health clinics, public schools, and primary care practices. In FY24, about 3,200 residents in the public behavioral healthcare system were managing their opioid use disorder with medication and counseling, and we are on track to increase this number this fiscal year with 2,000 residents treated in the first quarter. To expand access to youth with substance use disorder services, the Opioid Abatement Fund is supporting the Children's National Hospital Addiction Center to increase their hours and locations of services in Ward 8. In addition, the fund is supporting a youth-focused 24-bed substance use disorder treatment facility located in Ward 8, which is expected to open this summer. Crisis counselors and crisis beds are available day and night. The new DC Stabilization Center offers a safe place for individuals in a substance use disorder crisis to stabilize and get connected to care and other supports. To avoid disruption in care for people who might become involved with the criminal justice system, treatment units for men and women are available in DC jail. We are excited to announce that Fire and Emergency Medical Services can now administer medication to overdose survivors during emergency responses in home or in the community. To support continued treatment, we offer free transportation to treatment provided by DBH certified providers and medication-assisted treatment centers. Peer leadership and support are integrated throughout our strategies. 4 peer-operated centers connect people to treatment and provide recovery support services. The Opioid Abatement Fund supports peers who work within fire and EMS teams who engage overdose survivors. DC Health also is facilitating a drop-in center that offers health and wellness services, including access to harm reduction services, education, and linkage to behavioral health, medical care, and wellness activities. To increase the number of trained peers, the Opioid Abatement Fund is supporting multiple training efforts for both youth and adults with lived experience. Safe supported housing is critical for individuals to sustain a recovery, as we have heard today. Along with Oxford House, DBH has added a new model of recovery housing that provides intensive care management and counseling for individuals who may relapse in their recovery from this chronic disease. We also set aside recovery housing for men and women returning from incarceration. Currently, about 500 individuals, including 20 returning citizens, live in recovery housing. The Opioid Abatement Fund supports 75 transitional housing beds. With DC Health, we have established a robust data collection system that informs our strategies, including when and where to deploy outreach workers. The DC Health actively supports emergency response partners with improved data systems through the Overdose Detection Mapping Application Program. This enables agency partners to better utilize existing opioid overdose data and visualize real-time suspected overdose data, allowing for a timely response. The Office of the Chief Medical Examiner continues to play a critical role in the district's effort to address the opioid crisis by ensuring timely and accurate certification of overdose deaths, as well as contributing to surveillance and response strategies through advanced toxicological analysis. With the support of opioid abatement funds, OCME was able to enhance its toxicology operations, modernize lab systems, and improve data processing, all of which contribute to a more effective and responsive public health approach to the opioid crisis in the district. Through the work of community-based organizations, ward-based prevention centers, and faith leaders, we have focused attention on prevention of opioid use and combated the damaging stereotypes that addiction is a personal weakness or a cause of shame. Thousands of residents have participated in hundreds of community meetings and other activities to promote the understanding of addiction is a disease. The work of Live Long DC has reshaped the landscape by fostering a growing culture of awareness that substance use disorder is a chronic relapsing disease which can be treated. With the right services and supports, we can reduce opioid use, misuse, and abuse, and build thriving communities where all residents have the opportunity to live healthier and longer lives. This concludes my remarks. Along with our partners, I look forward to today's discussion. Thank you.
Thank you. All right, Dr. Zamore, if you want to join us at the table, I'll just swear you in really quick. We'll get to questions. I think we're working to try to get Dr. Diaz to be able to join us virtually. And so hopefully him or Dr. Tolliver will be able to do so. Okay, you raise your hand. Right hand, sorry. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
Yes.
Great, thank you. Okay. All right, so I just want to start at the very beginning for the benefit of the public. Can you sort of describe how each of your agencies play a role in the comprehensive strategy? So obviously, I know what Department of Behavioral Health does. Chief, I don't know if you want to speak a little to the work of FEMS in terms of the opioid strategy, and Dr. Zamore in terms of DC Health.
So DC Fire and EMS has a good partnership with the Department, DC. Sorry. DC Fire and EMS has a good partnership with the agencies listed here at the table, working together to work with prevention and as well as preventing overdoses. So we have a mobile integrated health team that works closely with the DBH to engage the community in prevention measures. They are also part of the team that that gives the buprenorphine that was talked about earlier to go ahead and assist with recovery efforts and also with working with the stabilization center to get those efforts coordinated. We have our Hands on Heart team that does hands on heart CPR, and in community events, they also pass out naloxone to engage the community and give overdose awareness to community members. Beyond that, our members in operations do the same thing. So we have all the fire engines, trucks, ambulance, medic units, and they also have community naloxone that they pass out. So that way, when they're engaging with the overdose patient, they can give the family member naloxone to keep with them, and then they'll go ahead and request our mobile integrated health team to engage the patient. So that way, they can continue to get services beyond emergency services when they're called.
Thank you. Dr. Zamore?
Thank you. I would say our role primarily is in data collection and surveillance, really assessing the scope of the problem, tracking it over time as it changes. I think in a situation like this where we have limited resources, we really need to deploy those efficiently and in a timely way. And we've tried to do that. We've also leveraged some of the relationships we have with our harm reduction and community partners to enact some of these activities. And I think because of our natural regulatory relationships with healthcare providers, that comes in as well as part of our response and our role in the school with the school's nurses.
Okay. Now, we talked a little bit in terms of the data around the statistics of what we've seen. When it comes to fatal overdoses, we've seen a significant decrease over the past year. We've been doing a lot of different things. Have we narrowed down what has worked the best in terms of reducing this number? 36% is significant in 1 year.
I really think it's the comprehensive approach that we have taken that certainly includes the full range of harm reduction techniques and strategies, prevention, intervention, treatment, and recovery strategies. I don't think we can point to any one thing, but what we have done is we have really implemented the best practices from across the country, the evidence-based practices that are proven to work, and employed those here within the District of Columbia.
Okay. I mean, but is there anything we weren't doing before that we introduced into our continuum last year?
Well, I think that one of the things that we have done that has really added to our system of care is the work that we've been doing around youth and really providing services and supports to youth. As you heard Dr. Colin Murphy earlier talk about the work that Children's Hospital is doing, we now have a 5-day-a-week clinic opportunity. He is opening another site, as you saw in Ward 8, and we have peers who are working to connect and to give information to our young people. The other thing I think that has been useful is we now have Too Good for Drugs that is being implemented throughout our school system, both in public as well as public charter schools.
Is that like a new version of DARE?
Pardon me?
Is that like a new version of the DARE program?
No, it's not DARE. I remember DARE from years ago when I was actually a teacher, actually. I used DARE. But Too Good for Drugs really is a little different from DARE. DARE was really just don't do it. This really talks about some of the implications related to drug use, and it also focuses on things like healthy decision making and making the right choice, and then how that can really prevent you from moving into drugs.
Okay. I mean, I think one new thing definitely was PHMS's new peer response team
Oh,
initiative.
absolutely.
Assistant Chief, I'd love to ask, and maybe this is a question for both you and DC Health, because you guys are doing some of this. One, you're responding, and you guys are sort of doing more of the surveillance work. What are the hot spots right now in terms of overdoses? Have we seen shifts in locations in the past year? Obviously, I think we've seen a lot of activity happening in 5, 7, and 8. But I'm curious if we've seen some new areas sort of pop up that hadn't been a hot spot in the past.
I can't say that we have any new necessarily hotspots. We're still battling some of the same areas, and they are getting a little bit better with more integration with our mobile integrated health team, because they include a community outreach specialist. And so we go daily to those hotspots. What will change is if there's this place where we previously haven't been, then we'll go ahead and we'll start to concentrate and engage that area a little bit more so it doesn't become a hotspot. So those are some of the tactics that we're using to make sure that we keep the community engagement on a positive level.
Okay. Dr. Zamore?
No, I think you're correct. The overwhelming majority of overdoses still happen in those hotspots that you referenced.
And that's both fatal and non-fatal?
Correct.
Okay. All right. Assistant Chief, what is the average response time for an EMS unit for a reported opioid overdose incident?
So our average response time for our EMS calls is just over 6 minutes. So.
Okay. Have there been any issues? I know OUC isn't here, but have there been any issues in terms of appropriate reporting from dispatch of like the call is for an overdose versus saying, oh, somebody is just in need?
No. So most of the time it's based on the caller's information. So we'll either get it as an overdose or we'll may get it as something more serious, such as a cardiac arrest, because of the when someone's overdosing, they may not be breathing as well. So that, But generally speaking, the dispatch is correct.
Okay. And in terms of, I mean, I was telling someone earlier, right? I see FIM staff out and occasionally seeing them actually doing the administration of the naloxone like on the street. Are there any concerns about the availability or accessibility of this particular drug at this point?
Not on our end. So we have, we keep track of the naloxone that we give out as far as for the citizens, as well as of what we administer to, as our patient doses. And so we make sure that we kind of project what we may need. And of course, we hope that we won't need as much every year and it'll continue to decrease.
Yeah.
Start to decrease.
Dr. Bethner?
Yeah, and I can say that we have a more than adequate supply of naloxone, and we use our state opioid response funds to support that. As a matter of fact, there was a huge delivery just this last week of naloxone, and all of our partners can get what they need on demand.
Okay. Assistant Chief, can you sort of explain what the difference is between the overdose peer response team and the never mind. Let me ask it in a different way. For the overdose response team, is it just peers who are on that initiative, or are you also integrating other types of community health workers?
So for our teams, we have a community outreach specialist. We also have EMTs and paramedics that respond, so that way they can address the medical needs. The community outreach specialists assist in connecting the patient with any services beyond just fire and EMS. So getting them to services the next day. So generally speaking, the community outreach specialist will check up with the person after an overdose after 24 hours. And then we do it every week until the end of the month, and then we'll do it every 30 days after that to make sure that we're keeping in touch with them to get them to the right services that they need.
So the continuity of somebody reaching out.
Right, and we, like I said, we'll work closely with the Department of Behavioral Health to make sure that they're getting the services that they need as long as they accept it.
How many individuals have been served through the response team?
I can't give you a specific number on that. I know for our buprenorphine administration, we're up to 14 right now. Our numbers are pretty good. We're trying to increase them, but because we're having good success with DBH, we're also coming across people who are also already being administered buprenorphine through the stabilization center or other services that they've been connected to previously.
Okay, that'll be helpful to kind of know that information for the public. The peer initiative or the peer response team initiative, the council directed some of the settlement funds to partially fund this program because we thought that it had a lot of potential and promise. Oftentimes when you guys have someone who, like, you do a call, you provide the naloxone, you reverse the overdose, they refuse transport. We don't want that to be the end of the contact, right? Especially if we're talking about someone for whom this is not their first interaction, this is not their first overdose, right? Like, what are the conversations that we can have with folks in that moment, in community with them? And so I actually think that this is super successful. How many team members are used for this project?
So currently we have 3 teams of 3.
3 teams.
So we have 4 teams, three teams of 3 that are active in operations, and then the 4th team is a team of 2 that mainly goes and focuses mainly on community engagement.
Okay. In terms of the various teams, is that so you could have somebody on every shift, or is it just to have broader coverage?
Yeah, so it's it's for their work schedule, so that way we have coverage every single day, and then one day a week they overlap. So there's 2 teams, and then like I said, the other team, they work more of a Monday through Friday kind of a schedule to make sure that they're engaging with the community. But we have coverage every day.
Okay. What data points are being collected to track the effectiveness of the program?
So we look at how many times we have come in contact with the person, if they're repeat users, how often are we engaged in that neighborhood, and various other data points to gather information on the opioid use. We follow up with DBH, DC Health. Earlier, it was talked about some of the other drugs that are being mixed in with the substance abuse. And so we're following those trends as well, because that affects the way our operational members will treat overdoses. So we've had issues with even after naloxone administration, where we have blood pressures that are continue to be lower, people that don't respond to multiple doses of Narcan. Earlier, they spoke about Narcan drips. So we're collecting all that data, and we're using that to drive our EMS protocols as far as how we're going to treat the patients, and as well as how we can better engage the community, even when we speak on the engaging the youth and how we can better work with the youth and in the older population.
Right. Council member, one of the things that I did also want to mention is that DC Hospital Association, as you know, works with us, and there are peers at all of the hospitals, and they also follow up on overdose survivors. And I think that that really has been a great benefit. In addition, in terms of the hotspot question that you asked earlier, one of the things to note is that we have really been convening the outreach teams that are working in the various hotspots to make sure that we have better collaboration and synergy among and between our partners. And we're really piloting a tool so that we can have really good information on what's happening by the outreach teams. And then we can look at what we need to do in order to make that process more effective.
Okay. I'm gonna shift to data collection and surveillance. I'm looking at the screen to see if OCME is gonna join us, because this is sort of relevant. So unfortunately, DC Health, since you're the one who's here, I'm gonna ask some things. What are some of the challenges DC Health is facing in terms of coordinating data collection and sharing? Or do you have any challenge in terms of data collection and coordination when it comes to this issue?
I feel some of the data points we don't necessarily own, but we've tried to be stewards and to integrate from our partners. I think what we've really added to data collection is our strategy in terms of looking at these overdoses as clusters or an outbreak and responding accordingly. I would say it's pretty hard to be specific as far as the case definition of an overdose. I mean, we kind of have to, we're not 100% sure what is causing it at the time. The only certainty comes when we test a needle or someone passes away, sadly. And I think there's a greater universe of drug use that opioids happen in, and we try to expand our focus to look at that as well.
Okay. Are you guys using data to predict future trends? Or?
Yes, we look at the changes now at a census tract level, really, from week to week. We can get down as specific as street corners in terms of the clustering that we're looking at.
Okay. In terms of surveillance, OCME's surveillance is usually like after someone has already passed away, or they're looking at the contents of needles. What is the basis of data that you all are looking at from a surveillance standpoint? Do you do wastewater?
No, we do not. That
Okay.
is something we had interest in doing in the past. It's just not an allowable activity from some of our funders.
Okay.
So for infectious disease, we've been allowed to do that, but not for drug surveillance.
Okay. It's very interesting. Oh, great. Dr. Diaz has joined. Dr. Diaz, can you hear me?
Yes, ma'am, I can. Can you hear me?
Okay, great. I'm asking some questions about data collection and surveillance. So you've joined just in time in terms of the work that you guys have been doing. So OCME received $400,000 in FY25 from the Opioid Abatement Fund to fund the forensic toxicology. did this allow for you all to do anything new in terms of your toxicology screenings, or were you sort of able to do a continuation of the things that you were already doing?
Both, if the answer applies, and the reason is both, it allows us to continue doing probably one of the most comprehensive postmortem toxicology in the United States, and new because the eyes cannot see what the brain doesn't know. Earlier, when we were in person, a lot of the panelists were talking about novel substances. Nearly every week, we have to update what we call the library. The library is reference material that comes to forensic toxicology laboratories, so the instruments can be updated. When I say that the eyes cannot see what the brain doesn't know, is that instruments cannot pick up novel synthetic opioids or other substances if the instrument doesn't know what they're looking beforehand. Forensic toxicology is a game of catching up. Because I'm older, I can tell you 30, 35 years ago, the issue was not that complicated because there were probably 10 different substances that users were getting addicted on. Nowadays, nearly every week, there is a new substance that is achieved by essentially tinkering with the chemistry or with the molecular configuration of substances. And that is what allows us to basically, using those funds, is to keep extremely up to date with what's going on. One day xylazine, which is prevalent in the East Coast, but next week could be something else or a combination of different things. I have next to me Dr. Samantha Tolliver, who is the director of the Forensic Toxicology Lab, in case you want to ask questions.
Okay, I have a further question on this. What's the average time frame for completing a toxicology report for a fatal overdose case?
On average, is if the postmortem toxicology is negative, then it will be within a couple of weeks. Depending on the complexity, the average postmortem of drug-related fatalities will be 7 to 10 different substances. We have a key performance indicator, which is 90% of all of our postmortems should be finalized within 60 days. As I testified a couple of years ago, postmortem toxicology is difficult because blood doesn't circulate on the dead people. It's a matter of comparing and contrasting different analytes that you get from different sides of the body. That's why it is labor intensive. It takes time, as opposed when people are hospitalized, for example, because blood is always circulating.
Okay. I guess this is a question for everyone. Like, what are the mechanisms in place to quickly communicate the emergence of a new threat or a new drug to public health or law enforcement officials?
I can start by saying that we do have a meeting with all of the partners on a monthly basis. And at that time, we get an update from every single one of the agencies that are involved in terms of what's new, what we need to all be focused on, and then we brainstorm on how should we address this particular issue.
Okay.
And so that's one of the ways we do it.
So I guess my question is a little bit different. I mean, that's great in terms of the monthly meeting, but I guess I'm really trying to ask, are there established thresholds or an alert system based on environmental surveillance data or perhaps on the ground data that would trigger a public health response? So let's say, for instance, FIMS is called to, like, you see a cluster of overdoses. Like, is there a threshold where all of a sudden you're going to say, hey, harm reduction groups, hey, groups who are in community, this batch is bad, we're seeing X?
So when we have spikes like that, again, like I said, we communicate with the group to make sure that the message is out there. As far as communicating with the public, that's it's a little bit different. FEMS doesn't necessarily push the message out as far as the public safety messages always. When we're as far as our social media presence that way, but with our mobile integrated health team and our crews, our operational crews, we push that message out that way to say, hey, this is a public safety concern. This is what's going on. You need to be aware of it. And then when they're serving the community, they'll go ahead and push the message out as well.
And also our outreach teams are then alerted, and our outreach teams then go to those areas and make sure that they have both naloxone on site, as well as they, talk to the folks who are there to see how they might be able to help and provide them with support. And that's just, that's a way that we can deal directly with those individuals within that community.
So I'll jump in as well. We primarily use ODMAP to do that. We do have a threshold where we look at the past 90 days. And whenever we see something significantly over that, we will send an alert out. We also define a cluster as 2 overdoses within 500 feet in a 24-hour period, and we would send information out there. I think there's also a qualitative aspect of the surveillance that's understated, and a lot of that comes from the relationships that have been built over time, where we hear things back that we should be vigilant for from the community.
Okay. Dr. Diaz, I saw you off mute. I didn't know if you wanted to add.
Yes, I do. If you allow me, I'm going to wear my other hat as the interim director of the Department of Forensic Science in a separate and apart grant that we have through the Centers of Disease Control. We do surveillance on paraphernalia, drug paraphernalia. It's called the syringe program, but it goes beyond syringes. It's all paraphernalia. That gives a glimpse into what people are using apart from fatalities. And the concordance that there is on paraphernalia that is found and fatalities that we have. And all that is communicated regionally and locally to the different stakeholders. There is a concordance in majority of the samples that are analyzed and the substances that are found. But sometimes, and xylazine is one example, xylazine is very prevalent in paraphernalia, not so much in fatalities. It also serves to us as a predictor in a way via communicating of the two agencies, what's out in the street and what may be coming in the following weeks in terms of fatalities. And so those are tools, those results are shared through a working group, as I said, regionally throughout the East Coast, as well as with local stakeholders.
Dr. Diaz, just to follow up on that. So looking at the data, it seems about like 27% in terms of your syringe testing has seen the presence of xylazine. Earlier, we had a witness who testified from MedStar Georgetown who spoke about the difficulty of xylazine being able to be detected bedside. Are there different approaches to an overdose of xylazine versus fentanyl or something else?
No, it is the same. And those are difficulties when you're testing in the living versus the dead. When you are testing in the dead, one of the few advantages is that you can go further. That you can preserve the sample, and the sample is not to degrade or metabolize into different things. So there's a better opportunity to capture what the person had via the byproducts. Because I don't want to go beyond my area of expertise, Dr. Tolliver, who's next to me, could probably expand on that answer.
Hello.
Hi, Dr.
Yes,
Tolliver.
hi. I heard the testimony earlier as well about the xylazine, and I would say that I believe MedStar said they had test strips for that. And I had mentioned to Dr. Diaz, we could, if they were interested, because there was mention of other drugs, nitazines, and I think metatomidate. where they weren't sure if those other medications were cross-reacting with that test strip. So that is actually an analysis that we could do here in the laboratory for them. If MedStar or any other hospital wanted to know, we could give them that intelligence so that they would know. Or if they wanted to purchase other test strips that they could use bedside, we could do some analysis on those as well and give them feedback for that so they would know what the parameters would be and maybe that would impact how they wanted to use that.
Thank you. I want to see this sort of connection. I appreciate you sort of mentioning this. I mean, the labs that you all have down at the Department of, well, the public lab, and then, you know, at DFS and others, it's a nice, beautiful lab that we paid a lot of money for. And I want to make sure that, you know, our public health organizations are able to call on you all when they need a higher level of analysis that they may not be able to get in their own labs about some of these things, to test a little bit of this. If we're starting to see more xylazine in community in terms of the substances, then I think it probably behooves us to figure out as much as we can around how to test for it. You know, is naloxone not effective against it? What are some of the other things if it's commingling, et cetera? And so I appreciate you offering up the lab to be able to partner with hospitals to do a little bit of this work. Let's see if anybody takes you up on that. A couple of final questions in terms of the OCME world. So we do have an opioid fatality review board. The last report that we see is from 2021. Is the board meeting? When should we expect the next report?
The next report should come out in the next few weeks, and that will include up to the most recent report. So we are in the second week of May. I expect the reports to be out on or before June 30.
Okay.
And if you allow me, I don't want to advocate for OCME, but one of the witnesses talked about earlier about pharmacogenomics. And I think you should consider funding through grants pharmacogenomics. That's the forefront of medicine because we are all different and some people react different to different substances. And I think that's a very worthy endeavor that will personalize the treatment of a lot of patients and will be beneficial. Some people really do not react to opiates. You give them opiates and it passes through them like nothing. And some other people, just a small quantity may result in a fatality. And the answers is in genomic studies. And I think that's a worthy endeavor. And that is forward thinking. I just wanted to say that, even though that's not my area, didn't mean to intrude, but I think it's a worthy endeavor from a scientific point of view.
No, thank you for that. I'm sure that the folks over at Howard School of Pharmacy will also appreciate the advocacy on that front, because this is something that they've been talking about for a long time. Dr. Basmar, you want to add to that?
Yes, I just wanted to follow up on what was said by the OCME's office in terms of xylazine test strips, and it is something we are also purchasing. And so we do have that as a part of our toolkit.
Okay. Wait, purchase like we have in stock, or will
We
we?
have, yeah, we have xylazine test strips.
Okay, that's good to know that that is available. Let's talk a little bit, I guess, then about getting that out into community and in sort of response to some of the witness testimony. My understanding is that DC Health manages for the vending machines, not DBH, correct? Okay. So, I mean, what's your feedback on some of the testimony we heard from HIPS about the trouble that they're having keeping those machines stocked?
I think that is a bona fide challenge that they have, because quite frankly, they just run out so often. They're tremendously popular. To date, we've given out over 90,000 elements from those machines. I think there's some variety in what goes in the machines. I think that might be part of it. But I think just genuinely they've been rolled out and we've used the information to deploy them in areas of highest use. So I think as we expand those machines and add more, probably we'll see those shortages less as people spread out to other machines.
Okay. Are there plans for expansion or?
There are plans to add another 6.
Another 6. When?
By the end of the year? Yes.
The end of the fiscal year. Okay. Okay. All right. An additional 6. So we'll follow up a little bit on that. Just to go back really quick, to sort of put a finer point, right? So we get public health alerts when somebody who has measles in Maryland went through the airport in Reagan National. Do we not send out public health notices at all? Okay, a cluster is 2 or more within 500 feet. But if you guys had a group of 10 or 15 people, I don't even know if that is even happening, but or 5 or 6 or whatever, do we not alert the community about that? I mean, Chief, you talked about, well, you guys tell your staff to be on the lookout for that kind of thing. I think Dr. Bazarani, you say we alert sort of community groups and organizations. But unless you're in the circle, you wouldn't know, I guess.
So I think a lot of the alerting is to people who have an action point, who we would expect to respond. We don't really restrict any access to the information. Anyone can join, but we found that the people who come on to consume the information are usually involved in outreach at some point. We do have an obligation to communicate with providers for things like medetomidine or other novel substances that emerge. But day to day, we're usually sharing information with our partners. I'm not sure what a communication strategy to the public would look like. That's kind of real time, like you're describing. We've tried our best to do that with the dashboard and trying to update that pretty regularly so people know where and just how severe the overdose problem is in the city.
Okay. All right. Let's go to youth and opioid efforts. Assistant Chief Edwards, we have someone who's testified from Children's. Usually, though, most of those cases get to Children's is a parent or a family member or a primary care provider has referred them to. In terms of what you guys are seeing on the ground, are you getting calls for young people in terms of overdoses?
We are, but for us, from a 911 perspective, they're not as prevalent. And then they're all different cases. So sometimes it is the youth who are using it, or sometimes they maybe accidentally got into it from older person relatives supply. And so, but we do have some calls for the youth, and we're working towards trying to engage with the school age children to go ahead and to make sure that they know the dangers.
Okay. Dr. Bazarani, you and I have obviously talked about what are the treatment options that exist for young people. And I want to give you an opportunity to give an update, if anything. I think you mentioned a facility that's about to open or is in the plans for opening. And I don't think that was the case a few months ago.
First of all, I'm really excited what Children's Hospital is doing. And that was such a great use of the opioid dollars. And here they have the clinics on the ground that are providing services and supports, and having that 1 day a week at the ARC in Ward 8 is real benefit. We also are planning a residential treatment facility for young people who need inpatient care for substance abuse, and we expect to have that up running soon. The grant has been awarded.
Right.
And so we are moving through that process, and this is a first, so we're really excited about that.
Okay. I would love to know more information about who's paying for what in that instance. Like, are we paying for, I know we provided the grant, but are we providing other additional financial support beyond that?
We are paying for startup, and also to help them in terms of ongoing operations. And of course, that particular grantee would be Medicaid eligible, and then they could bill for those services.
Okay. All right. Let's talk briefly about the commission. We heard from a number of the grantees in terms of the work that they are doing and the funding, but this is more in terms of the operations piece. So Yes, I was on the council in 2022 when we passed this legislation. In hindsight, would I have approved any legislation with 21 people? No, I would not. How's it going?
Mhm.
And do we feel like there should be modifications made in terms of the structure?
Well, I think that in terms of how it's going, I certainly attend those meetings, and the meetings are going well. I think that, initially we had to really uh, move through our group process. And as you know, when something is being newly formed, you have to set the structure and the process and so forth. And so now we have gotten through that. And now I think that, the group is working much better together and able to have discussions about how we should move forward. And I think some really good work has been done in terms of the grant making process and also making opportunities for people who are not the usual suspects to also get funding to implement some of the creative ideas that they have. So I think that that's the process. You know, I've worked in groups, and group is a part of what I have done over time. And it's a group large. I think all of us would agree to that. And so, that is a consideration.
Is the subcommittee structure working, or do you feel like it could be better utilized to focus on specific areas of work, provide more in-depth analysis and recommendations?
Well, I think both here again, as I said, I think that the subgroup structure is our first tranche. And so we will refine that as we move forward. I also think the steering committee is a good organizational structure within our broader structure, so that we can have a smaller committee that also kind of weighs in on some of our decision-making processes.
I could ask any of the other agencies, because you all have seats on this commission. I don't think that all of you are necessarily on it, but this is the opportunity to provide feedback in terms of the commission's work. Obviously, OCME is a little different because they've gotten money from the commission. Oh, so has FEMS. So there's that. Let's see. Let's sort of dig a little bit deeper into sort of the grants process. What transparency mechanisms are in place to inform the public about availability of funds? What is the process for application, and how the money is being spent?
Well,
So I would say sub question, right? If I'm a member of the public and I'm watching this hearing and I'm interested to see, wait, how is X amount of money being spent? Where would I go to find that information of who is a grantee?
First of all, the Office of Opioid Abatement can respond to how the money is spent, and also they're responsible for advertising the opportunity for grants and contracts, and they do that using through public announcements and also through community meetings. One of the things that we did, which I thought was extremely effective, is we had public forums where individuals from the community could come not only to learn about the opportunity, but how to apply and get their questions answered, and also to have the opportunity to discuss some of the ideas that they had. And I think that was very effective.
Okay, so I'm not going to tell everybody who's watching to just call the Office of Opioid Abatement to find out about the grant funds.
Well,
is it not on the website somewhere?
It should be on the website, yes.
Okay. Who sets the agenda for the meetings?
The chair.
Okay.
Mr. Jackson sets the agenda for the meeting.
Okay. Is there any involvement from the Office of Opioid Abatement in that
Certainly.
work?
Dr. Barker works with him as a part of developing the agenda.
Okay. And so this is sort of my observation. While we have the Office of Opioid Abatement, when it comes to the work of the commission, it kind of has like a hands-off approach in a way that I don't necessarily see with others. So we have councils and advisory commissions and all kinds of things across the government where a specific agency is the one who's providing support to it. So for instance, DC Health has a maternal health committee, or I think Department of Healthcare Finance does as well. Yes, you have a number of people and you have folks who are chairing those task groups or those working groups, but it is the agency who is saying, here's what we think the agenda should be, and is intimately involved in ensuring that we're progressing through to hit the points of the meeting and things like that. It feels, and in sort of the feedback we're receiving from members who are either on the commission or who are watching the meetings, is that DBH has had a different approach than perhaps other agencies, where it's more allowing the commission to drive everything, even at the expense of not getting all the way through what was planned for that particular day.
That hasn't necessarily been my observation. Dr. Barker is there. And actually, he, as well as, and he works with not only the chair, but also the co-chair in driving the meeting. In addition to that, certainly, I know I go to those meetings, and if it's kind of moving off course and we need to make a little mid-course correction, then we can do that in real time.
Okay. Let's talk about the grant funds in general. So we heard from some witnesses today about the delays in getting grants out. How are we rectifying those issues?
Well, first of all, I mean, I will say that, the grant making process, is one that we need to refine and improve. And one of the things that we're doing is building on some of the work that our partner, DC Health, has done and refined in terms of operationalizing our grant making process using the Salesforce platform.
Yes, a system. You
Yeah.
mentioned it at performance oversight. What progress has been made on a
To date, we actually are still working with DC Health so that we can get the information copied over to us, and then we will be able to move forward.
Are you
with it.
piggybacking on their license? What do you mean copy it over?
Yeah, well, I don't know if it's piggybacking on the license. You may know more about the internal workings of that, but I know that we have an MOU with them so that they can provide us with support in getting that system up and operating.
Okay. I mean, is that the main source of the delay? So for all of them, I mean, I got one organization who had 3 different grants, 3 different pots of money, all of them delayed.
No.
One pot came from us, one pot came from the commission, one pot came from SOAR.
And I think the other thing is to think about the grant making process. We have to also get information from the potential offerers. And sometimes that back and forth takes time. So for example, if there are issues around the budget, issues around needing further clarification in terms of their scope of work, there are things that they have to give us also. And so that also delays the process, that back and forth process.
Then if we have delays on the administration side, why aren't you delaying the grant timeline? So if a grant is delayed and by 5, 6, 7 months, but now you're still only giving me 12 months to spend the money, why wouldn't you extend the time?
I think that the grant funds are, consistent with our budget, which means that they are from, through that budget year. It does not mean that those funds are not available for the next year. And those funds can be allocated for the next year to fully fund, whatever that grant happened to be.
I mean, Dr. Balzar, you and I have had this conversation about grants before. And I would say this is not just you, it's for every part of this government. Why we don't start on grants until October 1 when you know you had the money. You've known since June that you had the money coming. It hadn't changed. Why are we starting to write the RFP on October 1, which means that you don't post it till December 1, which means then you don't award it till March 1, and then, oh, look, months gone.
Well, actually, for the opioid abatement fund, that grant process actually took place in July, which was before the beginning of the fiscal year. So we weren't writing the grant application at the last minute. Yeah.
Yes, you wrote it in July, released it in July, awarded in October of 24, but no money went out until March of 25. So that's still
And here again, this is a process.
from July to March.
Right. There's a process that, as I said, that we're refining. As I said earlier, we do recognize that we need to improve the process, and we are putting things in place to do that.
Okay. I mean, I will say the same about the community outreach grant. I know Councilmember Parker isn't here, but in the 5 months that it took for some to get the money to be able to do some of this additional work, I probably pull how many overdoses have happened at North Capitol and P Street, where we could have probably had people on that corner or doing that work to engage people to move them into recovery and other things. So when we are talking about grant delays, I can appreciate administrative challenges and concerns, but when we're specifically dealing with opioids, somebody's life is happening in between that time that it's taking for us to be able to pull the pieces together. When's the next round going to be posted?
We are planning at this point to be able to announce within the next month and conduct the next round within shortly thereafter.
Okay. So you all recently rolled out Live Long DC 3.0. How do we evaluate its effectiveness?
How do we evaluate? Well, there is a process that we use to evaluate the success of the various aspects of the program. We do that in partnership with the Live Long DC members and look at what's working and what's not working. And remember all of the things too that we are supporting through our grants and contracts have evaluation metrics. And so we look to see what's working and what's not working.
All right. One of the things that came up in testimony today that sort of consistently happened throughout from the public witnesses is this question around housing. I know that's kind of outside of OCME's scope. It's definitely outside of PHMS's scope. So I guess between DBH and DC Health, are we looking at this? I mean,
absolutely.
How are we sort of approaching it? Now, obviously, that's a larger expense, a longer period of time, and would hit less people. I think Samaritan's Inn said 24 people that they were able to put in terms of transitional housing, but that's certainly not the biggest need. So are we looking at this as a scope? Obviously, we've got some priority areas, but this seems to be the one thing that kind of slips through the cracks.
Well, I can say that housing has been on our agenda from the beginning and a priority because we recognize that when somebody is in early recovery, you know, safe, clean housing is essential. And so not only do we fund the Oxford houses, and we have added additional slots there, but we also are funding a transitional housing that also has other clinical supports through that's really consistent with the NAR standards. And that's new, coming online as residential housing supports. We also fund environmental stability housing, as you know, and that is a place where we're also increasing it. And it's a need. And we need to tap into every particular resource that's available so that we can continue to support as many people as possible.
Okay. The other thing that came up in testimony that I'm very interested about is sort of this, you know, we talk a lot about Medicaid, but now we've got a Medicare sort of challenge here, particularly around Part D when it comes to MAT.
Right.
What's eligible, what's paid for, et cetera. Have we thought about what our strategy is there, whether it be DC Health or, and maybe this is more a question for Department of Healthcare Finance as opposed to the two agencies here of when I hear about stories around opioids around the country, right? There is this sort of narrative and framing that this is very much like a 20 to 26-year-old problem, which could be the case for certain jurisdictions. But I feel like for us, we're dealing with,
Older
I would say, a unique population, which is older adults. And so that requires a little bit of, I would say, additional flexibility in terms of the Medicare piece around how we help these individuals who are suffering. And so I guess my question I'm interested in is sort of what kind of conversations are we having with CMS? Are we having conversations with CMS? And so that's why I'm wondering whether or not this is a healthcare finance question, which I'm happy to follow up with
Yeah, I
them.
think healthcare finance would be best positioned to respond to that.
Okay. As we do a look out into the next year, what's the one thing that each of your agencies is planning to sort of double down on in terms of further reducing the numbers of fatalities and non-fatal overdoses?
So for fire and EMS, we have a new division that's working on a community risk reduction plan. And so we're working through that right now to gather all the data from all the calls and information that we have access to. And with that, we're also looking at increasing the staffing for our mobile integrated health team because of the work that they're able to show that is positive and working. And looking at ways to, again, just engage the community as a whole with the entirety of the fire department and the various divisions and bureaus.
Okay. How many folks do you have on the mobile integrated health teams now?
It should be 11.
11, okay. Dr. Bazemore?
I think that here again, I would not want to say we're going to focus on one thing because we know one thing isn't the answer. We want to continue our harm reduction priority and focus on the range of services and supports that can help keep people alive.
I would say expanding our data infrastructure, being able to capture and integrate more information from the 18 agencies that are part of this strategy. I think we'll also continue some of the relationships that we've built and really leverage those to make change. But I think we'd also like to move past the event and start looking at people and take a more longitudinal view of drug use in terms of looking at outcomes and trying to prevent overdoses.
Okay. Dr. Diaz?
Same, I adhere to what was said. I think going back to the structure of the abatement committee, I echo what Dr. Bashram said in the sense that at the beginning, there needed adjustment in terms of how we were going to work. But I think in the last 6-7 months, I think that it's been working smoothly. So I don't think that any substantive changes need to be made. That is my opinion. I echo your sentiment about grants, even though as a recipient of that specific grant, we got it really fast. The frustration from the two agencies in terms of federal grants is what you said. They approved the grant, disbursed the money in the month of May, and we have until September 30 to act on it. And that's across the board through all the grants that we have from the federal government. So that's a pervasive issue that agencies have learned to live with it. It's not fair and it's not easy to deal with in terms on how you project and how you try to budget your time and allocate your human resources to specific projects. But that's an issue that is larger than this committee. Anybody that deals with grants deals with the same issue.
I know, but I don't want that to be the way of life. Because I feel like we're wasting money. I have folks, if you have from May to September 30 to spend it, now you're all of a sudden spending on things that you didn't probably need because you're just trying to expend as much as you can to build up. So
100%, and I had a grant. Once you receive money, one shouldn't complain. But I asked for a grant for OCME, and I asked for 100,000, and instead was granted 300,000 with only 75 days to spend it. How can you spend it? You know, you can't. And those are the perils. Yeah, you're absolutely right. And
Speaking of grants, Dr. Diaz, and I'm going to wrap here. Did you all receive the funding for the forensic toxicology in FY26? Is that going to be in the budget?
we haven't yet. We haven't.
Okay, all right, we'll discuss that further when we get the budget. Does anybody have anything they want to add that I haven't asked?
I just want to thank all of our 85 community partners and 18 agencies and the chair, Chad Jackson, and our co-chair, Jacqueline Bowen, for the work that they're doing, because none of us can do this alone, but together I think we can make a real difference in the lives of people with substance use disorders.
Thank you. All right, and with that, that concludes our roundtable today. While the recent decrease in fatal overdoses certainly offers a flicker of hope, I don't believe any of us feel like we should be complacent. Hopefully this roundtable has reinforced the critical need to maintain robust investments and unwavering dedication in our efforts to combat this crisis, ensuring that all district residents, particularly those most marginalized and disproportionately affected, are receiving the support and resources they deserve as we move forward. I want to thank everyone for being here today and for providing testimony. For anyone who was not able to speak today but wants their voice to be part of the record, we're accepting written submissions of testimony until Wednesday, May 21st at 5 p.m. You can submit it online on the DC's Council's Hearing Management System site. And with that, this roundtable is adjourned. Thank you.